Let's start. Come on, silence there in that room. Come on. Silence here and silence there. No, you show her face now. Yes, we want you have to make the announcement. Okay.
Good morning, everyone. Today is 4th September 2018. Welcome to SANJEEVINI JNANA YAGNA. Today we are going to start with the prayer. Saraswati Namastubhyam Varade Kamarupini Vidyarambam Karishyami Siddhir Bhavatu Me Sada. We are going to start with the webcast. Today's webcast is History of the Discovery of Estrogen and its Implication.
Session, and it's been a lot of fun basically putting it together. Over the last 2 millennia, actually, progress driven by astute observations of multiple investigators in this field. And it's interesting how the research findings have been rapidly translated into the development of clinically applicable hormone preparations. Discoveries led to the birth control pill, treatment of breast cancer, menopausal hormonal therapy, the treatment of primary amenorrhea, and many other aspects. And during this time, there have been really multiple controversies that really are not resolved to date. So our approach, we can't cover everything. We're going to try to cover some of the interesting highlights, and we'll concentrate a lot on the rationale for the experiments, the controversies, and then the identification of the 3 types of investigators contributing to estrogen research. And I'm going to quote from Fuller Albright, who you all know as a giant in the field of endocrinology, having described postmenopausal osteoporosis, one of his contributions to estrogen, the Forbes-Albright syndrome, the McCune-Albright syndrome, primary hyperparathyroidism, and of course he trained the eminent investigators, Drs. Kleinfelter, Reifenstein, Forbes, and many others. So Fuller Albright, in his book, quotes Oliver Wendell Holmes, the famous US Supreme Court Justice. And he talks about 3 types of investigators. 1-story intellects, those are all fact collectors who have no aims beyond the facts. 2-story intellects, they compare, they reason, they generalize, and they use the labors of other fact collectors as well as their own. And then rarely there are the 3-story intellects. They idealize, they imagine, they predict. Their best illumination comes from above the skylight, which we interpret, this is inspiration. So the outline of the talk, I will begin with the classical period to the development of the pill. Evan will talk about biochemical advancement, mechanisms of estrogen action, and estrogen synthesis by aromatase, and then I'll talk about some of the clinical applications of these findings. When we think about this, observers think about estrogen. Well, they really only had the ability to look at patients. And if we go back to 1323 BC, we see King Tutankhamun, a endocrinologist in the room, clearly seems to have gynecomastia. But some have postulated that the gynecomastia is merely. But I think when we look at this, this looks like true gynecomastia. And in fact, his brother, Shmenkare, had gynecomastia. And if you look at his family, there were 4 family members that had. So from this, we would think that probably this is due to familial aromatase bias, but the genes are now becoming available from King Tut, and we may well be able to make this diagnosis over the next few years. Well, the next question, what did the Romans know about this? Well, Cyrannus of Ephesus, who worked in the 1st and 2nd centuries, made a number of observations. First, breast development and menstruation occur at approximately age 14. This is interesting because we were taught that 3 centuries ago, the average age of menses was age 17 and has gradually reduced to age 12 now. And yet in the Roman times, they thought it was much earlier. Both the male and the female, he thought, produced seeds necessary for conception, and they had contraception. So blockade of the cervical os was an effective means of contraception at that time. His competitor was Galen of Pergamon. He was the physician to the Roman Emperor Marcus Aurelius. You know, this was the philosophy emperor, and we still read his deliberations. And he was really considered the most accomplished of all medical researchers of Western antiquity. However, he made some errors. For instance, he postulated that menstruation was a natural form of phlebotomy. So women had to get rid of their evil humors once a month, and this was a way that this basically could happen. Obviously, this was maybe a bit of misinterpretation. Let's move forward to Thomas Wharton, 1614 to 1673. Now, the medical students will recognize that he was the individual that described Wharton's duct. But he was interested in ductless versus ductal glands. And he thought that the ovary and the testis are similar, have ducts. And he recognized that damage to the ovary results in infertility. And therefore, the ovary must also produce sperm. Not illogical, but obviously wrong. The French contributed to this. Augustin Nicolas Durand postulated that menstruation was related to ovulation, the first time that someone contradicted the thoughts of Galen on this. And this was in AD 1885. Well, we all know about Claude Bernard, who really came up with the concept of internal secretion. And this is the first time, really, that we go from the transition from our observations clinically to experimentation to find out what actually is happening. So he wrote a book in 1885 on experimental medicine, and he's considered the father of experimental medicine. His observation was that glucose released by the liver would go to many tissues in the body, and therefore this was a form of internal secretion. Well, this led really to the whole field of internal secretion, which was from about 1880 to maybe, and there were 3 specific steps that were needed to do these studies. One, you had to remove the gland and document ensuing signs and symptoms. You then had to transplant the gland back into the body and demonstrate reversal of those signs and symptoms. And thirdly, you had to administer the extract of the gland. This is organ therapy in patients lacking that gland, and at that time demonstrate reversal of the signs and symptoms that would occur. So when did step 1 take place? This was Robert Batty in 1880 that developed oophorectomy that he could do safely. This was called the Batty operation, and it was done for dysmenorrhea and bleeding from myomata. Well, he noticed that this was associated with hot flashes and vaginal atrophy, and it led to the hypothesis that the ovary makes something, some type of substance, that in its absence causes various symptoms. What was the second step? Well, Emil Nauer removed the ovaries in rabbits, which caused uterine atrophy. He then transplanted the ovary at a distant part of the rabbit and sustained normal uterine size. So from this, he concluded that the ovary makes some type of internal secretion. And this was in 1896. Step 3 is quite interesting. Hubert Fosbury, who was a physician in London in 1897, and I'm quoting, "When at last the patient's period ceased, the patient was much troubled with frequent and violent flushings, which at night in winter would wake her up, the face being in burning heat. So he ordered 5-grain palatinoids of ovarian glands." So this is organ therapy. And this is a form of medicine capsule, which was ground up and administered to the patient because he said the ovary tastes terrible. And he would give this 3 times a day. What was the result? The findings rapidly became less frequent and intense and were nearly cured by the time 3 dozen palatinoids were taken. So this was in 1897. And I think when you read this, you really think that this therapy probably worked the way he described it. So we all think about the history of organ therapy. And it was Brown Sequard, really, who's considered to be the father of organ therapy, with the concept that administration of an endocrine gland would ultimately relieve the symptoms of estrogen and hormone deficiencies. And he first suggested that the ovarian therapy for women might be effective once the ovaries were removed, but he actually never did it. When you go back into history, you find out that people who you thought were very precedent were not. And it turns out that San Si Miao was really the first person in 652 to describe organ therapy. He was called the king of medicine, by the way, by the Chinese. And what he did is he treated goiter in the mountainous regions of China near Xi'an, and that was known as a goiter bout. He utilized extract of deer or of sheep thyroid to the patients, and he described in very clear terms the efficacy of the therapy. Those of you that can read Chinese, which I'm not very good at actually, he's describing here the preparation of deer thyroid for the treatment of goiter. At the same time, Evan came to the fact that the Chinese in 10B were using isolated urinary products, which probably contained sex steroids, for treatment of a number of conditions. It's interesting to look how they did this. They took 150 gallons of urine, they heated it to facilitate evaporation, they sublimated it, got the residue, scraped it off, make it into pills, and they administered 5 to 7 pills. You had to do this with wine or soup for it to work. They made this urine extract and used it for male urine for hypogonadism, impotence, and beard growth, and female urine extract was used for dysmenorrhea. This was described by Robert Temple in his book, The Genius of China. And I would challenge anyone in the audience to go back and use this methodology and see how many steroids were actually in the urine. Probably was correct. So at this time, applications of concepts known at that time were very rapidly translated into clinical therapies. This is Sir George Beatson. I call him a 3-story investigator. And here's what he thought about. He compared the major proliferation of breast tissue with that of malignant breast tumors, histologically. And he learned that oophorectomy in lactating cows in Australia prolonged. So he concluded that the ovary has some type of regulatory role on breast growth. So he took this idea, removed the ovaries in women with breast cancer, observed both complete and partial regressions, and hormone therapy for premenopausal patients. So at that time, the Endocrine Society was founded. Further studies were conducted. Now, the Endocrine Society at that time was called the Association for Study of Internal Secretions. And many of the studies were really presented here. But look, this meeting was held in 2 days at the Bedford Stratford Hotel in Philadelphia, and they only for the meeting. We've come a long way since that time. So who found and crystallized estrogen? Well, there were 3 key people involved: Adolf Butenat in Germany, Edward Doisy, and Edgar Allen in St. Louis. an interesting story that Edgar Allan started by observing the effects of castration in mice and rats, into the rats, and observing both vaginal maturation, receptor, rat to sexual mounting. So already we know about behavioral effects, like sugar and weight as a Allen-Doisy test, and it was measured in rat humans. His studies at the time appeared to result that makes estrogen, and he concluded that it was the ovarian follicles because that's where he gets estrogen. But we know that there's the theca cell, which makes androgen, which is aromatase to estrogen. So we now have the two-cell theory. So he was actually not correct. It is that Edgar Allan and Edward St. Louis and Edgar Allan, they both had to go to work in the morning, and Doisy had a Model T. So Doisy was an organic, and Allan needed someone to isolate and purify the internal secretion he was testing. So after long discussions driving to work, they agreed to work together. And Allan provided the follicular fluid and Doisy purified it. So this was really difficult work. They couldn't get much from the follicle. The practical breakthrough, Elmar Aschheim and Bernard Zondeck in Germany reported that the urine of pregnant women contained large amounts of fully purified estrone from the urine. So here's Doisy presenting at the 13th International Physiologic Conference in 1929 in Boston. He called estrogen thelin because of thelos, which is Greek, and you can see the abstract below. This was a 10-minute talk describing estrogen. This was the key. This was a countercurrent multiplier that he used to purify and crystallize estrogen, and here are the crystals. In his later article, he said these were the first crystals 20 times since, and we get the same result. Now, an interesting coincidence is that who was sitting in the front row but Fuller Albright, listening to this presentation. So we know the comments of Fuller Albright at this talk through the book that Len Lurio put together, The Uncharted Seas by Fuller Albright and Reed Ellsworth. The potency of these crystals is so great that 1 gram could restore the sex cycle in more than 9 million castrated rats. Sex crystallized and weighed, and the audience only clapped. So Albright recognized in this 10-minute talk immediately that this was really quite important, but he looked around and nobody else seemed to be excited by this finding. But clearly he must have thought about the clinical applications of this. Well, Buchanan comes in Germany. He hasn't attended this session, but he learns from one of his trainees that Doisy has, I can't use the word Trump, has superseded his work and presented it earlier. And so he had been doing all of the same work. So he hurried into press and got his publication out in 3 months. It took Doisy 6 months to publish his work. And and Buchanan wins the Nobel Prize for this work, not only for estrogen, but he also purified testosterone as well. Doisy had to wait another 20 years to get his Nobel Prize, and that was for purification of vitamin K. Well, one of the early controversies was whether there were 4 cyclohexane rings or only 3. And you can see that Buchanan has got 4 hands up here because 4 fingers up here, because he thinks that there are 4 rings. Doisy, who's standing next to him, isn't so sure. And Miriam on the right side is just trying to ponder whether either Doisy or Buchanan is correct about this. So this was in 1929 and 1930. By 2 years, you can see that every drug company had made some sort of an estrogen that could be used and tested in patients. So this happened very, very rapidly. And the availability of this stimulated immediate clinical studies. So here's Fuller Albright again. In 2 years, he demonstrated that estrogen blocked hot flashes. In 5 years, he showed that estrogen blocked bone loss And in 6 years, he demonstrated that estrogens could block ovulation. It's interesting, it takes only one patient to show that this preparation works. So you can see here that when he's giving estrogen, shown by the patch bars, the number of hot flashes go down. He stops the therapy, they go back up again, treats again, they go down, stops, they go up. This one patient tells you that this therapy is effective. And it's really the brilliance of clinical observations. Now, Albright knew that estrogen stimulate bone growth in the male pigeon. Here's the male pigeon on the left, and you can see that there's very little bone here. After 36 days of estrogen, this is what the bone looks like. So he knew this. And knowing this, he basically spent several years demonstrating that estrogen provided effective treatment for osteoporosis. Now, again, we didn't have bone densities and all the studies that we could do. So what he did, basically, he said, look, we have women who have lost bone over the time before they start estrogen therapy. Some a substantial amount, lost height. Some losing a substantial amount of height. But once we start estrogen, these patients no longer lose height. And in this group of patients who hadn't lost height before the menopause, again, he could completely stabilize height after that. Again, clinical science showing that estrogen really works in this situation. Now, one of the other things that came along is that there was the development of an animal model for breast cancer. This was Charles Huggins, and it really contributed to the movement in this field. As you all remember, Charles Huggins was a Nobel Prize laureate for orchiectomy for treatment of prostate cancer, but developed estrogen-dependent breast cancer models. I had the chance to ride in the taxi with him when he was 94 years old. And I asked him, Dr. Huggins, why did you switch to breast cancer? You've done prostate cancer your whole life. Here was his response, and I'll paraphrase it. The Ben May Laboratory had no operating room, and I had to take the dogs to Northwestern in my wife's station wagon. One day, she said, Charlie, your dogs are no longer going to be foul in my station wagon. You better start working on something else. He did. He developed the DMBA breast cancer model, and it's one that we use commonly. So one of the next highlights, I think, is the development of the pill. This is the first bottle of Enivit that some of you might recognize. And there were several key aspects of development of the birth control pill. Fuller Albright, of course, had shown that estrogen blocked ovulation. Russell Marker went down to Mexico and found Mexican yams and could synthesize progesterone from that. Gregory Pincus and Min-Chu Chang demonstrated the block of ovulation with progestins. And then, of course, there were clinical trials involving the gynecologist John Rock. But I'm going to specifically comment on Margaret Sanger and Catherine McCormick. So here's Gregory Goody Pincus, clearly a three-story investigator. Here's Min-Chu Chang, really underappreciated for the work that he did. This is John Rock, who was a prominent Boston gynecologist. Now, what did Margaret Sanger do? She had been advocating birth control for a long time. Her quote back in about 1910, "No woman can call herself free who does not control her own body." We've heard that a lot recently, and she said it a long time ago. Catherine Dexter McCormick, and you'll recognize the name McCormick, she was the inheritor of the Cyrus McCormick fortune. And Cyrus McCormick invented the McCormick Reaper. And of course, the McCormick Center here is named after this family, so it brings it home. So several issues generated controversy. Contraception was actually illegal in many states, in Massachusetts until 1973. Margaret Sanger had championed the use of contraceptives for many years and formed what was called the National Birth Control League, but it's of course now called Planned Parenthood. Interestingly, she'd been convicted of violating the Comstock Act because she mailed information regarding contraception in the mail and was basically arrested for that. And her work obviously has continued and quite a lot of controversy. So what did Catherine McCormick have to do this? She had a huge fortune, and she provided about a third of the funds that were available for development of birth control pills through the Worcester Foundation and the Pincus Group. So she really contributed not only financially, but she sat on the board that was evaluating this and had scientific connections as well. So these were two women that really contributed substantially to this issue. There was another controversy, and that is that the Catholic Church declared oral contraceptives to be artificial and therefore not moral. But the interesting thing is that they commissioned 70 experts to look at this, and the majority of opinion of the panel, 60 individuals, said that the birth control pills were fine, this was moral. The 10 in the minority did not. If you want to read this, the majority report was leaked to the New York Times in 1966. It says an analysis of the majority report about recommendations for abortion, sterilization, and contraception. Well, Pope Paul VI actually took the minority report, and to this day, the Catholic Church says that with birth control pills is artificial and therefore not moral. It's estimated that 65% of Catholics don't believe that and use oral contraceptives. That's an interesting story that maybe someday will get resolved. So what happened? So the laws were changed to allow oral contraceptives. There's now widespread acceptance worldwide. And the first practical ability of families to determine the number of children. Now, condoms were used since the time of the Roman Empire, and the rhythm method, some consider this to be analogous to Russian roulette. So there were substantial changes in the role of women in society and in the workplace because of this. And putatively, when you think about this, this has been one of the most powerful influences on several social aspects, including sexual behavior, general roles in society, and the economics. I'm going to turn the podium now to Evan Simpson, and we'll go on a bit more into the mechanisms and synthesis. Evan? Thanks.
Okay, thanks. So let's start a discussion of the history of the cellular and molecular biology of estrogen action and synthesis. Initial studies depended on the development of radioisotopes of high specific activity, namely tritium and carbon-14, which are used to label steroids such as estradiol. And of course, leading developer of this field was none other than Albert Jensen himself, who had many contributions. He demonstrated the specific uptake of estrogen into target tissues, which he postulated to be due to an estrogen receptor. He showed that estrogen receptors identified which breast tumors were hormone dependent and predicted responses to endocrine therapy. Moreover, he stimulated his mentees to purify the estrogen receptor and study its detailed molecular mechanisms. And this is one of his early prismatic studies, if you like, where he used radio-labeled estradiol to, and it studies uptake in tissues of the rat, specific uptake in the uterus and vagina, but not much in other tissues. So nowadays, of course, estrogen receptor functionality is studied by literally scores of people, among which is Jeff Green with the cloning of the ER alpha, Janaki Gustafsson cloning the ER beta, and genomic actions have been investigated by numerous investigators, including Ken Korak, Donald McDonald, John and Benita Katzenellenberger, Sarah Bill, and many others that we don't have time to today. Interestingly, non-genomic actions of estrogen were first shown by Clara Sager some 30 years ago, but this work was largely forgotten until more recently, where it was picked up by Ellis Levin and others, and now, of course, this led to a great expansion of our understanding of the mechanism of action of the estrogen receptors. And here is Janaki Gustafsson. Here is Jeff Green, who is, of course, a principal mentee of Elwood. And Jeff purified the ER alpha. He cloned it, he crystallized it, and determined the crystal structure of the ER binding domain, the ER alpha binding domain shown here. And on the left-hand side, bound to diethylstilbestrol, and on the right-hand side, bound to 4-hydroxytamoxifen. So this is a diagram of the action of estrogens, both at the genomic level and at the non-genomic level, which I think was presented by Benita and John Katzenelnbogen at the time of the Koch Award from this society. Now, of course, a lot of the data here, the details here have been filled in subsequently compared to what was at that time. And here are John and Benita in their laboratory. Here's Ken, I think probably on the golf course. And here's Donald McDowell. So moving on then to discuss the estrogen synthesis. Initial studies were conducted as far back as 1934 by Bernard Zondig, who postulated that androgens might be converted to estrogens. And then there was Steinach and Kuhn, who, I quote, injected large quantities of male hormone into male patients and determined the excretion of estrogenic substances in the morning urine. So this was postulating a precursor product relationship between androgens and estrogens. And we know now for sure that the only way you make estrogens is from androgens as a precursor. Then further studies were conducted by Ken Ryan in central aromatase. Harry Brody studied the biochemical steps in the aromatase reaction, and Penty Citri, better known as Finn, used radioactive methodology to quantify aromatase. And this is data from Finn Citri with Paul MacDonald, where they studied the uptake, the percentage conversion of androstenedione to estrogen via aromatase in males and females as a function of body weight. And you can see that going from, say, 80 to 360 pounds, there's about a tenfold increase in the conversion of androstenedione to estrogen, clearly indicating that this mostly was derived from the adipose tissue. They also looked at this as a function of body weight, and showed this also caused an increase in the conversion. Age, I guess age, I'm trying to say age. This also showed an increase, indicating that aromatase expression in adipose tissue increases as a function of aging. So moving on, the purification of aromatase was worked on by a number of investigators shown here. And this was followed by the cloning of aromatase. And this shows the full-length cDNA of the human aromatase gene. And this again was the work of a number of investigators. And this led in turn to analysis of the structure of the human aromatase gene. Now this is an interesting gene. It's quite large, but it's characterized by having upstream of the start of translation a number of untranslated first exons shown in red, which are spliced into the coding region shown in yellow in a tissue-specific fashion due to the presence of these various tissue-specific promoters. Each of these has a unique set of trans-acting coactivators, resulting in specific expression of unique sites in the tissue sites of expression. So this shows, if you like, a diagram of a breast, adipose fibroblasts and the epithelial cells, both of which express aromatase. And in this tissue, aromatase androstenedione is converted to estrogen, and then on via 17-bit HSD to estradiol. But this androstenedione is actually a circulating precursor, which is produced either by the adrenal or the postmenopausal ovary. So this is an example then of the concept of endocrinology established by and pushed by Fernand Lebris. This is here Susanna, who, among many other things, demonstrated aromatase and other steroid synthesizing enzymes in both benign and malignant breast tissue using immunocytochemical techniques. And the regulation of aromatase was studied by, among others also, but by Christy Brown, specifically in adipose tissue and including adipose tissue of the breast. And she showed that in this tissue, leptin actually stimulated aromatase expression, whereas adiponectin inhibited it. Interestingly, she also showed that metformin inhibits aromatase expression in breast tissue. Now, recall that there's a lot of data now suggesting that metformin actually inhibits the proliferation of a number of tissues, tumors rather, including those of the breast. And she also showed that P53, which is a tumor suppressor, inhibited aromatase in this tissue. And she also showed that the oncogen HIF1 alpha is stimulated aromatase in this tissue. So the study of aromatase in the human placenta has been conducted by Carol Mendelsohn and her group. And this slide shows a diagram from one of her papers in which you see a large number of transactive factors bound to the aromatase placental promoter, and this is responsible for placental-specific expression. Now, studies on the aromatase structure were also moving ahead at this time, and early studies were conducted by Xian Chen at the City of Hope in California, and he developed models of aromatase structure based on the structure of known P50 enzymes at the time, and also, of course, the sequence, the amino acid sequence. And his models were actually remarkable and very close to the real thing. And the real structure, of course, was determined by Dr. Gosh in Buffalo. And now, he did not use recombinant cDNA of aromatase to express aromatase protein to crystallize it. He actually purified the aromatase from human placental microsomes and then crystallized it from this, which to me is an extraordinary achievement. And this shows the crystal structure of human aromatase and P50 purified from placenta by his group. And this shows a close-up of the reaction center. Let me just show of the aromatase P50. Here is androstenedione with, in this case, the C19 methyl group pointing towards the iron in the heme prosthetic group at the heart of the reaction center. Now, the reaction mechanism has also been worked on quite extensively, and for several years, controversy arose as to the exact nature of this third hydroxylation step here. However, I believe this was finally settled by Fred Gingrich and his colleagues, Dr. Yoshimoto, at Vanderbilt University, and I think this sequence now. So let's turn to the male. So the work of Smith and Currick and others some years ago, case of clinical estrogen caused a man. And you see he's extremely tall. His height is 204 centimeters, and he has genovalgum or knock knees, and very remarkable is a consequence of bone undermineralization. And you see his growth, whereas most young men stop growing just at the late teens, he kept on growing right through his 20s. And you see here in this X-ray of his hand the unfused epiphyses here, and this is clearly filling of the epiphyseal closure. Now, here's another patient. This is a patient of and he also has continued linear growth into adulthood with evidence of unfused epiphyses and delayed bone age, and as you can see clearly, genovalgum. When Cesare studied this patient, he assumed, or he thought this was going to be another case of ER alpha mutation. So he sent the DNA from this patient to Ken Currick, who sequenced it, and Ken failed. He couldn't ER alpha mutation in this patient, and he couldn't find it. So he said, and we showed that this patient actually had in the aromatase gene, an inactivated mutation in the aromatase gene, phenotype very similar to the patient with ER alpha deficiency studied in that patient. And once again, he has continued linear growth into his 20s, and at the actual age of 24, his bone age was 14. And again, you see the unfused epiphyses. And in this patient and the patient with ER alpha mutation is that this patient can be treated with replaced with estrogen. And when that was done, they did not extend any further. So, and these patients present an important, if you like, a nature. Up to this time, it was assumed that in men, testosterone was responsible for the maintenance of bone mineralization. For patients clearly showed this was not the case, that the mineralization both males and females was under the control of estrogen and not simply testosterone in the male. Now, it turns out that estrogen has other effects in these patients also. This is another man with aromatase deficiency. And if you look at this panel here, he's clearly got type 2 diabetes. The values of these numbers here. And this is after estrogen treatment. And you can see his liver function parameters are sky high. And also they're after treatment with estrogen. So we include estrogen has an important role to play in the maintenance of energy homeostasis and results in changes, it regulates lipids, enhances insulin sensitivity, lowers glucose, and normalizes. And this just shows an example, a biopsy from this man's liver shown here. It's a guard which is triglycerides. But after a year of estradiol treatment, there's a marked improvement in the liver. And that's very similar to the liver of a male aromatase deficient. See the lipid droplets in his liver, again, mainly triglyceride. And again, this is normalized by 6 weeks of estradiol treatment. Okay, so now, So, again, much information is altered animal models. So Ken Clark and others generated ER, our understanding of this. Also generated aromatase knockout mouse. Mouse models of aromatase overexpression have also been generated by Maddie Putin and his group and Raj Tekmal. That's and in addition to the phenotypes we described, there are also disruptive organs in males and also disrupted spermatogenesis and decreased sexual function also occurred. So I'll now hand back to Dick here, who will finish talking about clinical implications.
So let's talk the clinical implications of what we've been talking about. So one of these was the estrogen to treat. The first actually was by Dr. Cole in 1971 at Christie's Hospital in Manchester. And of course, later there were extensive studies by tamoxifen and also other SERMs. We then for hormone-dependent breast cancer. There were a number of individuals that worked for steroid aminoglutathamide. And Angela Brody, whose husband, Harry Brody, had been working on aromatase synthesis, developed steroidal inhibitors. And then came along the prevention of breast tamoxifen and aromatase and measurement of estrogens as risk factors for breast cancer. Bill McGuire was he, along with did an extensive correlation of the presence of estrogen receptor in tumors with breast cancer responses to hormonal therapy. But more than multiple concepts about breast cancer biology, progesterone receptor, the role of pathology, the endocrinology, and so on. Clinical studies of aromatase inhibitors, it's kind of interesting to think about this. The first demonstration of blockade of aromatase in postmenopausal women with breast cancer was with a it took only 5 patients, basically, to show that. And this is using the series isotopic kinetic study to show the androgen to estrogen in postmenopausal patients. And you can see in only 5% reduction in aromatase, showing that this medication clearly does its job. Angela Brody worked with her group, and you can see that they synthesized a huge quantity of 4-hydroxyandrostenedione, then established the first trial, really, of a selective aromatase inhibitor in Great Britain, and this was with the compound 4-hydroxyandrostenedione. Unfortunately, Angela succumbed to an illness just about 4 months ago. So we go back to Charles Huggins, and some of us like statistics and some don't. He clearly didn't. So he says that if your therapy works, you don't need statistics to prove it. This certainly was true for anti-estrogens and aromatase inhibitors for breast cancer. This patient presented, postmenopausal patient, presented with a lytic metastasis of the 7th cervical vertebra and a large lytic metastasis of the ileum. 6 months after aromatase inhibitor, this completely recalcified, as did this. She had no more pain. She gave up her wheelchair, and clearly this medication was working. Other things can be quite visible. This is a patient with metastasis in the skin and also a second breast cancer on the other side, completely regressed after 6 months of therapy. So clearly, these early studies showed that these anti-hormonal therapies worked in patients. Well, another question is, does estrogen prevent breast cancer? The Women's Health Initiative trial, which was somewhat criticized, of course, has now undergone a 13-year follow-up. And at the end of that period of time, comparing the women on placebo with the women on conjugated equine estrogen, there's a 23% reduction in breast cancer incidence in women ages 50 to 79. This is really called the estrogen paradox, because estrogen is thought to cause breast cancer. And there's why this might occur. One of them is the role of apoptosis in breast cancer. Another is that conjugated equine estrogen has clearly different properties than estradiol. So our understanding of estrogen action in women and its application becomes more complex each decade. Read this slide, but there are effects on brain, on heart, on the vasculature, of course on the ovaries and bone, on breast, on adipose tissue, and major effects on brain. We don't have time to talk of basically all of these. So another controversy that is still out there, does menopausal hormonal therapy with estrogen cause benefit or harm in postmenopausal patients? So the recent Endocrine Society guideline suggested that the benefit exceeds harm in women if they have symptoms of menopause and if their age is 50 to 59 or less than 10 years postmenopausal, and they have a low risk of breast cancer or coronary heart disease. This is really precision medicine. You tailor the therapy to the patient, and if a woman meets these qualifications, symptomatic and low risk of estrogen, it can be useful in this situation. And we hope that these guidelines may have helped a little bit with respect to this controversy. So what did we leave out? We left out a tremendous amount, and we just had to choose what we could pick. And clearly, the effects of estrogen on the brain, behavior, gonadotrophin regulation, obsessive compulsive behavior, its cardiovascular actions, its effects on the immune system, pubertal development, management of menopause, actions in skeletal muscle. And we've left out all of the investigators that have worked to allow this story to gain a fabric and to gain a great deal of depth and strength of evidence. I would refer you back to the publication that Evan and I published in the Journal of Molecular Endocrinology, celebrating 75 years of estradiol. And we do try to mention all of the key investigators and also the citations to those individuals. But with that, Evan and I thank you so much for your attention.
This is being recorded. Madhumati, 100% silence. But nobody to talk in the room, close the door. Okay. Science and good job. I want to know silence, please. Hari Om, 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 Hari Om. Namaste. This is a very special day for me because this is perhaps in my 62 years of life one of the best scientific presentations, one of the top best presentations of my life. You saw how many Nobel Prizes. Those of you who missed this, go back, listen to it. I call eternal bliss, supreme ananda, when you attend Tejomayananda or Paramatmananda's Bhagavad Gita class. This was equivalent. The last several minutes was so equivalent to the greatest spiritual lecture I heard. When Reshma suggested this lecture through her link, I was wondering why she picked up estrogen. Not a hot topic for endocrinologists. She picked up this class. That I'll tell you. But she did a marvelous job. I have several points to make. Bear with me. Equally good. I'm willing to forget Bhagavad Gita and do this because it makes difference to people. Please, those of you who have not read, including Gita, everybody, sit and listen for several reasons. Number one, the depth of science. And the speaker is a phenomenal speaker. And the American guy who spoke. Later, Banu will give his comment as an internist with a broad depth. He categorized three types of people: single story, double story, three story, to give insight, and fuller outright. Several of them belong to the how to pick up things which are important. And perhaps this is one of the best lectures of endocrinology which I have read. Due to lack of time, I am going to summarize it. Young people like Monica should read this. Even I am sure Uma and they will enjoy it because there are several major implications to it. Between you and me, I was transported to heaven during this whole lecture. Initially, I thought some mystery, Claude Bernard, etc. See the social implications. See the challenges of contraception. The ADA conference center which took place is called McCormick Center. How Mrs. McCormick donated. The other lady who is a champion of human rights, what she did. The controversy of the church, etc. How science history has blended. You admire the Chinese medicine. There is similar thing, not to be selfish and proud. Indian medicine is much more ancient than Chinese medicine. There's a problem with India. All this philosophy, spirituality makes you not aggressive. In China, if there is no religion, they are aggressive. Here you tolerate everything. It is the religion as in. See, Chinese have progressed much farther in the middle part, though India is more ancient. Egypt, India, China, every field. How much they have done? Urinary steroids. Just listen to it once again. People may give letrozole, aromatase inhibitor. You are giving tamoxifen. Everybody is giving tamoxifen. For breast cancer, everybody giving letrozole. Yesterday also she saw. See the number of investigators, thousands of investigators, each one who have contributed their share. It is the organic chemists, fundamental scientists, and the clinicians pick it up. And you know, Endocrine Society was started in 1980, Society of Internal Secretion. Now they got a name has changed. Even in India, I requested Professor Ahuja to change Research Society for Diabetes in India to a simpler one, Diabetes India. Okay, now, so many things. And you also realize it's an old society. You have realized the Endocrine Society webcasts are much more intense and depth than ACE. ACE is more clinical drug company. My sister doesn't like to attend ACE. Those are old timers prefer Endocrine Society. Though it may, the complaint was rat mouse culture, these become too clinical trials, etc. Now, Endocrine Society has also become clinical. It is the, if you get a chance to attend, you should attend Endocrine Society. That's what people say. It is good for practicing doctors. I can't cover everything, my thoughts about this lecture. It was a brief lecture. I couldn't imagine in that whatever 30-40 minutes, how much of science was pumped in. The biochemist, I never knew Chinese. You heard the Ashim-Zondek test for pregnancy, how the follicular fluid. See, in endocrinology, you are talking of one substance, estrogen. This is the story of estrogen. You know, estrogen, there are three ones. Estrone, E1, E2 is the estradiol, E3 is the estriol. The active form is estradiol, E2. How it was one of the foundations of endocrinology, even the step 1, step 2, step 3. I think one thing interesting I thought in this talk, Claude Bernard, who got into the bandwagon, he's supposed to have done implanted a bovine testis on in his abdomen for his own reduced virility. He was working. He told over he put testis, some cow testis, because he wanted to increase his masculinity. That is there in the literature. How much history has been covered? I never realized. See the amount of people who have contributed brick by brick. I was wondering at least one Indian name came. It was the Europe and American. Some were European, some were American. America, because of wealth, everybody, including Albert Einstein, migrated to America. So that is the strength of America. And you saw 1929 Endocrine Society, Boston. And then you see the Japanese getting involved. You saw. Then Chinese got involved. That was really, and one Devashish came, but he's an Indian in Europe. He had crystallized it, etc. Okay, Indian science far away. We are millions light years away, and everybody uses estrogen. You give HRT, oral contraceptive pill, Mala D is in every village, 2 rupees per month. But how much work took place to do? Go back this weekend, listen to this again, this webcast, send the link, slowly observe. It is high quality science. I will make your life a little easier. We'll be getting the big board in a short time so that I could have written. Without the board, let me tell you a few things which may be little relevant. Why Reshma, Bharnaki, Harsha fell in love with estradiol this today? Many of you not know. Why all of the, see, in terms of our clinical workload, diabetes, thyroid, obesity, etc., hardly we use estrogen. But why she wanted history, because there is today's little bit of flashback on some of them. There are 2-3 interests. How many oncologists prescribe aromatase inhibitor? They won't bother. They won't bother the mechanism, the structure. Okay, it was ovary. You imagine somebody thought ovary made sperms. How knowledge evolves, and it will continue to evolve. Ovary, from ovary, ovarian extracts, then pregnancy, then identification of estradiol, identification of ovarian contribution. Estradiol is secreted in the adipose tissue. Male hormone conversion of androgens to estrogens. Placenta is a big source of estrogen. Brain, estrogen. Estrogen is synthesized in peripheral conversion from testosterone. So many aspects were covered. All of you, starting from Pushpa to the counselors, can sit together with a doctor and just listen to this one. It may be on the top of the head. Today there is no time, I could have stopped and made the entire estradiol Gita in a very simple way. Now let me make it clinical. There are two patients this week, one handled by Reshma, another handled by Kavita, which are centered on estrogen. Kavita saw a estrogen case, a lady on letrozole yesterday, and we had a discussion. And Reshma saw 3 days ago another fascinating case related to estrogen. There were two top-class estrogen cases. Number one, I will start with the easier one. Okay, but one more thing. Ovaries, they make androgens. Testosterone and androgens are the precursors of estrogens. Okay, and testosterone is converted to estradiol. There is a crucial enzyme called aromatase. How long they took to identify that enzyme? And you saw the 4-link structure, cyclopentano, and none of them have double bonds. Aromatization is the ring A becomes double bond. That is aromatase. So aromatase converts testosterone to estrogen. Peripherally also, wherever it exists. And aromatase inhibitors is a major thing in, I think we had one of our staff members, and my sister had, we have 3 cases of letrozole this week. One is Reshma's case, another is Kavita's case, different. Kavita is not, Kavita's is letrozole. One of our staff members' husband was given by my sister letrozole to increase sperm count for its anti-hypoestrogenic effect, so that it increase LHFS and decrease. Letrozole infertility. So we'll discuss all the 3 cases which are clinical cases. First, Reshma's case, which involves estrogen but not aromatase inhibitor. Second, yesterday's case of breast cancer of Kavita and Kamala, which involves letrozole. Third, a case of male infertility where letrozole was given to increase the sperm count. 3 cases of estrogen. The first case of Reshma Harsha. We got referred a case from Tumkur, a young 17 or 18 with primary amenorrhea. Reshma will present this case briefly next week, very briefly. She can, I think she has sent the summary. One of our PHFI students, this girl had primary amenorrhea. Some workup was done. Phenotypically a female, but her karyotype was 46XY. She did not have breast development. We worked her up. So she is 46XY, disorder of sexual differentiation. 46XY is DSD. DSD is a broad term. Many of you have seen. And she's brought her chromosomal sex is male, her genetic sex is male, it's XY. Her gonadal sex is testis in the inguinal region. And number 2, her phenotypic sex is female. It's an incomplete female. She doesn't have any Mullerian structures, no fallopian tube, no uterus, no upper third of the vagina. The lower third of the vagina blood pot, which is from the urogenital sides. She didn't have breast development. It's one of the rare cases. We worked her up. They have done a test called FISH, fluorescent in situ hybridization. This girl has 46XY chromosome. Parents were done. They were normal. Mother was not done. Sister was done. Okay. Incidentally, when we saw this girl, they said, my younger sister also has primary amenorrhea. And we thought, okay, dono ko ek hi bimari hai, usko bhi bulao. Fortunately, the younger sister story is very simple. She doesn't have the disease. She just has PCOS. That is 6XX PCOS, totally unrelated. Now coming to this girl, I'll make it short. Coming to this girl from Tumkur, we don't use names, we use L and V. So she's 46 XY. We checked out, the gonads were in the inguinal region. She had 2 lumps in the not palpable inguinal region. Obviously, they are testis. It has descended into this. External genitalia female, blind vaginal pulp, no internal structures, no breast development. Stature fine. She is normal stature. What do we do? A wonderful, the child has gone to Trivandrum. The child got completed an engineering. She has got a job in Wipro, doing very well, very, very positive. See the sigh of relief to the parents when the second kid doesn't happen. Now, there were 2 diagnoses. I should tell you, a lot of pediatric made a wrong diagnosis. The same phenotype you find in another condition called severe androgen resistance, otherwise known as testicular feminization. There, they are XY. The androgen receptor is completely resistant. They present like, they brought up like female. They have primary amenorrhea. You check it out, they don't have any uterus. The testis makes Mullerian hormone, but complete androgen resistance, testosterone is sky high. It is androgen resistance. So the testis makes testosterone. And number 2, the testis make Mullerian inhibition factor or AMH that regresses the Mullerian structures. But they have gynecomastia. This one because their testosterone doesn't work, and whatever estrogen is high, so the estrogen testosterone ratio will be high. They look like pretty females, and you can't do, they can't in it. The only one patient we had, a Muslim patient, they chose to get married in Malya, and they have to do vaginoplasty. People know they cannot bear it. They are 46 XY, testicular feminization. But this girl we are talking, her testosterone levels were quite normal. In androgen resistant testo is high, LHFSH also is in the higher side. Because androgens are produced by the testis in plenty, it does not work at the receptor, it also does not suppress the pituitary. So typical profile in complete androgen resistance is testo high, like hyperinsulinemia, and LHFS also high. This girl had, I'll tell you, she had little high, not very high, 17, 20, but testosterone was normal. So it is not androgen testicular feminization. There is a particular disease called as 46 XY gonadal dysgenesis. There is something called mixed gonadal dysgenesis where you have XY, XO, the same patient is born. This is 46 XY gonadal dysgenesis. 46 XO gonadal dysgenesis is Turner syndrome. Okay, 47 XYY is Klinefelter syndrome. You saw Klinefelter or Fuller-Arkwright student. Fuller-Arkwright is considered the father of American endocrinology. So there is Fuller-Arkwright award, so many McCune Albright, so much. Okay, PTA. Mass General Hospital is a parathyroid, that hospital has developed like that. Now come back. So what we did, this girl underwent bilateral orchidectomy because any gonad which is not in the scrotum is prone to malignancy. Any dysgenetic gonad is prone to malignancy. So this is a dysgenetic gonad which is there. So she got it removed. Once we removed, probably it was making very little. It was making low testo. The LHFSH have gone to castration level. Once we did, it has gone to 75. Such it has become. So whatever little inhibition has gone. So 46 XY gonadal dysgenesis. The differential diagnosis, complete androgen resistance or testicular feminization. If you have partial androgen resistance, your genitalia is ambiguous, partial fusion. But external genitalia is female. So the androgen resistance is big from hypospadias, complete female, big, you get big spectrum. This is complete. leave that. So our case is 46X5 achondrogenesis, and the differential is testicular complete androgen resistance or testicular feminization. The biochemistry will be different. There you have gynecomastia. Here you don't have. The breast in that girl is gynecomastia. Here, now come back. This girl, both the gonads, testes were removed, and now she's on replacement therapy. Her genetic sex is male. Her chromosomal sex is male. Her external phenotypic sex, external genitalia, is female. Her psychological sex is female. Her sex of rearing is female. Okay. And number two, one more thing. Height was good. Okay. She's slightly morphonoid, and because of estrogen deficiency, in her case, she's male. The testo is not there. She has delayed bonate. No, bonate we didn't do. She has osteoporosis, means her bone density is less. Am I correct? You saw, no? Yeah, no, BMD, we got the BMD done. Her BMD is low. The BMD is low, the Z score. Now, what do you do for her? Number one, she has been replaced with estradiol. Very interesting. Myself and this is one of the first cases I've dealt with directly as a primary. If 2-3 people involved, we share the decision. We wanted to decide, she has no uterus. So what to give? Now she has to become a full female. So we started around estrogen. We debated whether we should give OCP, whether she needs progesterone. In a woman, if you give, suppose you have another primary amenorrhea due to ovarian failure or hypopate, with an intact uterus, you give estrogen till their uterus becomes normal, unopposed estrogen. Then you give progesterone so that they have cyclical bleeds. You need cyclical bleeds to prevent endometrial hyperplasia, etc. So, one second, I will answer everything. Just keep down your question. The discussions are much deeper. Okay. Write down your questions. I will answer you. It will flow. Your question is right, but the discussion is it's a rare case. So, in a normal primary amenorrhea, hypogonadism in the female, either ovarian or pituitary, you give unopposed estrogen, endometrium develops, breast develops, then you give progesterone. Estrogen develops your endometrium and your breast. Progesterone causes the secretory phase and you got withdrawal bleed, you get cyclical bleeds. Even in the breast, estrogen is responsible for the development of the ducts, and progesterone is important for the development of the lobules. For lactation, you need progesterone for the ducts, estrogen for the lobules, and you need prolactin for promoting lactation, and you need oxytocin for milk ejection. 4 hormones, estrogen. So you need for the breast. Now, she doesn't have uterus. She is like a hysterectomized patient. Now, take estrogen replacement in a lady who has been hysterectomized at the age of 35. She doesn't have bleed. So you give estrogen only. In earlier postmenopausal HRT, intact uterus, you give cyclical estrogen and progesterone. Our women used to start bleeding. Do you know, when we were in ERTC 90s, we would convince the women to accept bleeding till they are 65, so to protect their bone and heart, etc. And after that, women have the estrogen was supposed to be highly cardioprotective. I keep reminding you, Washington Manual, one of the 1995 editions, the treatment of hypercholesterolemia, the first agent for treating dyslipidemia is estrogen in women. It reduces LDL, increases HDL. Reduces, okay, and but it also causes little rise in triglycerides, cardioprotective. But that is gone after the Women's Health Initiative. A estrogen replacement therapy is gone. for cardioprotection because statins have come and you have bisphosphonates osteoporosis, but they are finding a subset. So in that era, for postmenopausal, I'll go fast. Uma I given so much. We used to give primarin and conjugates. Primarin or conjugates is from equine estrogen conjugated, and we would give delivery. We had written, in fact, we were using so much, we had typed it and we would circulate it to women. Tick the box. If you have a uterus for postmenopausal hormone therapy, it is cyclic estrogen progesterone for a woman who acceptably, woman who doesn't want to bleed, it is unopposed, this one, but yeah, it's a little tricky because you may develop, you have to rule out thromboembolism, mammogram, family history of breast cancer indication. But for a hysterectomized postmenopausal woman, you are safe. You just give estrogen because you are not bothered about the uterus or the breast. That is postmenopausal. 30-35 intact uterus removed. So the ERT depends whether you have an intact uterus or uterus gone. This girl is not hysterectomized, but she doesn't have a uterus. So madam gave her estradiol only. The girl is on estradiol. Do we give 31 days, 30 days? No, it's 21 days cycle. So you mimic it. In this girl, the estrogen, there is no uterus, nothing. Rest of the structures it may help, but her estrogen will help her bone growth, breast development. And number two, estrogen will give all the other benefits he wrote on the last slide. So, okay, that's one. That case is over. Now, that is to do with, we have started estrogen, but it has nothing to do. What about the two cases of aromatase inhibitors, which we are discussing? The earlier case, I will take the first case of breast cancer. There is a patient of Kamala called UK who came yesterday. She had breast cancer, postmenopausal. She has undergone, she got adjuvant chemotherapy and then she got the breast removed and it worked very nicely. She did not have any distant metastasis. She might not have. But now the oncologists give them bisphosphonates. Hey, by the way, you also understood how metformin reduces proliferation. It's an inhibitor of aromatase, so many things. Now let me come back. Because some of the people who are watching, if they watch, they won't understand why we are jumping the tracks. Now come back. UK, postmenopausal, breast cancer, adjuvant chemotherapy, followed by surgery, no metastasis. They give. You know, the oncologists give bisphosphonate right, left, and center. I have told Kavita will post to you the indication for bisphosphonates in a post-menopausal woman for cancer therapy. Bisphosphonate osteoporosis is endocrinology's fault. But bisphosphonate for cancer therapy, a little bit for pain, there is little data for reducing metastasis. Once a drug company makes it, they want the indication to agree. And for oncologists, giving IV infusion is their bread and butter. The nurse will start. So they give all drug infusion and they give. So this lady is going through bisphosphonate infusion. All of you know bisphosphonates have some side effects. You should know in America, the number of people using bisphosphonates have come down. And out of the two effects, we saw still good drugs, you have to be careful. One is called osteonecrosis of the jaw in people. And number two is atypical fractures of the femur. Both are common when you give high dose bisphosphonate for cancer patients, not for postmenopausal osteoporosis. Okay, they read this. This lady is cured, but still the oncologist is calling every 6 months. The moment you put the head cancer, the patient forgets all other primary care doctors. The moment the patient thinks you have renal failure dialysis, the only thing is dialysis. They forget the endocrinology. Same thing. I wanted to know how long you have to give, how long. This lady, UK, is now only on hormone therapy. She is taking letrozole. You know, tamoxifen. Now, there are two drugs. One is letrozole, which is an aromatase inhibitor. Others are SERMs, selective estrogen receptor modulator. One was roloxifene, which is an anti-osteoporosis drug, not popular. Clomiphene is popular. Clomiphene is also a SERM. Roloxifene is a SERM used for osteoporosis. Clomiphene is a SERP which is used for ovulation induction, and tamoxifen is a SERP which is used for breast cancer. They are all anti-estrogen therapies. How do you do to anti-estrogen therapies? One, you block the estrogen, you give an estrogen receptor blocker, so whatever estrogen doesn't work, or you prevent the synthesis of estrogen. Tamoxifen blocks the action of estrogen. It acts at the estrogen receptor level. Whereas aromatase inhibitors cause estrogen deficiency. They block the synthesis conversion of androgens to estrogen. So their action is different. Very interesting. See, one of the side effects, estrogen you need for postmenopausal, premenopause, etc. If you give anti-estrogen, they are all anti. So tamoxifen is an anti-estrogen. Aromatase inhibitors are the synthesis inhibitors. They thought if you give anti-estrogen, the woman will develop, you are trying to cure breast cancer, women will develop osteoporosis. No. It was found out that those women who are on HRT, tamoxifen for breast cancer, this drug acts as an antagonist at the breast tissue, so they don't, it's good for breast cancer, but it acts as an agonist on the bone. So all patients, when you have blocked the action of estrogen, you are blocking it in the breast, but in the bone you are agonist. So women who are on tamoxifen for breast cancer postmenopausal, their bones are stronger. It is as though you are giving estrogen for. So estrogen is an agonist on the bone, does the good job, but in the breast, that's why it's selective. Okay, tamoxifen story is over. But on the other hand, so tamoxifen people, you don't have to worry about the bone when they are on cancer. But aromatase inhibitor people have estrogen deficiency. So Dr. Nidhi has told this lady, as long as we give aromatase inhibitor, continue bisphosphonate. Okay, because we are causing estrogen. See, postmenopausal lady has very tiny estrogen that you are causing deficiency. I am not sure of the rationale. Okay, whether first one, the oncologists, when they give bisphosphonate, they don't look at the BMD, they are not bothered. Okay, so she is going to, Kavita will send little, what are the indications, proved, unproved, etc., of bisphosphonate therapy for malignancy? What are the benefits? Will it reduce pain, reduce metastasis, reduce recurrence, and how long to give? And do people, estrogens, postmenopausal estrogen is little bit, even that you are blocking. She will clarify that. So that is the story. The patient is on letrozole. And one more thing, if a patient with breast cancer has a normal bone density at the time of breast cancer surgery, then you have nothing to do with osteoporosis. Will your letrozole cause osteoporosis? Do you need BMD monitoring in a cancer patient? See, all of you know, once BMD is normal, we don't bother rest of the life. Okay, now that question. Now, second, so the second aromatase inhibitor story is one of our patients has a little oligo. It's a very tricky patient. There is a primary gonadal slight deficiency, sperm count for 35, 40 million. Unfortunately, unsystematic follow-up in this building with multiple doctors doing hodgepodge medicine. Now she has taken over by Kavita under the supervision of Kamala. There is evidence of a pituitary deficiency also. There is a complicated situation. My sister in desperation had put her on letrozole. I've never used for male infertility. She had put on coenzyme Q and curcumin. She has given none of this are approved medicine. So she used off-label for a desperate situation. Fine. The person developed severe neuromuscular pain, bone pain, and crying with pain. So we stopped. The patient developed a toxicity. What is the there are some off-label studies. What is the rationale of giving letrozole and reducing the estrogen level in a male? I will come to the interesting part of estrogen in a male. If you give aromatase inhibitor to a male around say 40s, his estrogen will come down. Theoretically, that may keep to kick up the LHFSH and then improve your sperm count. And I don't know whether, see, the system is so complex. Even with extensive research, I don't think we know everything. Whether estrogen has a direct effect on spermatogenesis, whatever. There has shown that if you reduce estrogen levels in a male, infertility counts increase. Off-label, we stopped it. Better to go for, okay, now. So the story of estrogen is over. Now, long time ago, everybody was thinking, now let us move to pubertal development. Estrogen is female hormone, testosterone is male hormone. That was the concept. But testosterone has a role in it. Estrogen is the dominant female hormone, testosterone dominant male hormone, but men have little estrogen, women have little testosterone, they do the job. One of the roles of testo in women is conversion, is a source of aromatase. And both of them, both estrogen and progesterone, both of them are responsible for skeletal maturation. If you have estrogen deficiency in the female or testo in the male, you develop osteoporosis. Both of them, if you give pre-pubertally, they will accelerate the growth. You will grow faster. Both of them will fuse the epiphysis. So they grow tall and they fuse. Precocious puberty, etc. So these are the effects of both of them. Increase bone formation, that is reduce osteoporosis, bone remodeling. Number 2, estrogen is an anti-resorptive agent. It's classified. Both of them promote bone growth, bone formation, and number 2, the deficiency of both gives rise to osteoporosis. Estrogen is an anti-resorptive agent, but in terms of the epiphyseal growth in a prepubertal, it accelerates epiphyseal growth, advances bone age, and fuses it. So you grow tall and then ultimate height will be short. Same thing. Now, what they found is, this also my sister has discussed in one of the classes here. People started investigating the role of estrogen in a male. How this whole thing was, there are 2 conditions. Now we are only talking what does estrogen do in a boy. There are 2 diseases, case reports. One was a estrogen receptor alpha mutation. Boys, we are only talking boys now. If you are born with estrogen receptor alpha mutation, please, they grow tall, they have genu valgum, they have delayed bone age. You saw all that. Growing tall, genu valgum, bone age. It's a, and you saw the development of osteoporosis. The first case he showed was an estrogen receptor mutation. The second case, which had almost similar presentation, tall stature, had an aromatase deficiency, genetic aromatase deficiency. What does it mean? These are boys. That means either if the estrogen doesn't act, or if the estrogen is deficient. When there is estrogen deficiency or estrogen resistance, the boys continue to grow. So because why? Estrogen is also responsible for the closure of the epiphysis, even in the male. And there is thing I have to read that for boys to close their epiphysis, estrogen is perhaps more important than this is based on the 2 cases. And now they have developed. So if either your estrogen in a boy, we are only talking boy, estrogen doesn't work because of receptor defect, estrogen is not synthesized because of congenital deficiency, they are tall. So estrogen deficiency or estrogen deficiency resistance prevent epiphyseal fusion and you grow tall. What is the difference between the 2? If it is aromatase deficiency, you give, and you know their growth spurt is in the puberty. Check it, the growth curve, you saw how much they grow. But if the aromatase deficiency, you give estrogen, it will prevent, it will work. You should give estrogen right from the beginning, and it will prevent, because it works like type 1 diabetes. Whereas in an estrogen receptor defect, even if you supplement estrogen, doesn't work. So 2 diseases in the pediatric group. In a boy, estrogen receptor defect, aromatase deficiency, tall stature. Another interesting corollary. Okay, one more thing. Not only that, these patients, because they aromatase deficiency, estrogen treatment helps. Receptor defect, it doesn't help. He showed a beautiful diagram. Why estrogen is good in a male? The person had aromatase deficiency. He had high lipids, glucose and insulin, and he had NASH, fatty liver. LFT was abnormal. This is a patient with aromatase deficiency. They give estrogen to these boys, everything becomes normal. So estrogen improves lipids in the boys, estrogen improves glucose, and estrogen is fatty liver. Now, so 2 models. So it has a effect in the. Now another interesting thing. All of you know there is a condition called constitutional delay in growth and puberty, which doesn't need treatment. Very rarely, because of pubertal delay, you can give little estrogen. It is a normal variant short stature, not a pathological short stature. There is a concept. These people have delayed puberty and they become short. You want to make them tall, give letrozole, the aromatase inhibitor, as a treatment, so that you, what does aromatase inhibitor? Estrogen fuels the epiphysis in a boy. So you give aromatase inhibitor, so they will continue to grow. So if you have a short stature boy due to CGDP or even familial short stature, and you are sure epiphysis, so letrozole has been proposed, I don't know the stature, as a treatment of short stature in a male to delay the fusion epiphysis. Estrogen fuses, you give letrozole, whatever little estrogen that boy is making, he will stop making it and he will continue to grow. Once he has reached the stage, stop the letrozole. And now let us turn to breast cancer. Okay, you have seen how much this work led. So again, to estrogen-dependent breast cancer, treatment is tamoxifen by blocking the estrogen action, or by aromatase inhibitors by causing estrogen deficiency. So the treatment of estrogen-dependent breast cancer is to produce pharmacologic estrogen breast cancer or pharmacologic estrogen deficiency by giving aromatase inhibitor. Am I correct? So you saw now how much it has evolved, and you saw the beautiful experiments of this cone. Now every village they use letrozole, everything, and but do those doctors know, oncologists know the mechanism it works, and extent of which this was also a historical journey of endocrinology, what you saw. So aromatase inhibitors, so treat estrogen-dependent breast cancer by producing estrogen resistance by tamoxifen or estrogen deficiency by aromatase inhibitor. Tamoxifen, no osteoporosis here in man. Okay, now last point. TDGP is over. Another very interesting thing. See how science. Estrogen known to cause breast cancer, but they showed data that if you give particular estrogen, conjugated equine estrogen, it prevents breast cancer. You saw that life table analysis. This was in the World Health Initiative that studied, which made you, the ERT was universal before. I keep telling you, I've given lectures copying from gynec endocrinology that it is as important for a postmenopausal woman to eat estrogen daily as it is for men and women to stop smoking. So can you imagine our village patients were accepting, and we used to tell them, you're 58, your periods have stopped 8 years ago. I want to protect your heart and bone. Would you accept bleeding? Swamiji, we used to brainwash them and they would accept bleeding. And they bleed. Once the endometrium atrophies, they stop bleeding. Okay. But you know, one more thing, any endometrial bleed during ERT, you have to undergo a biopsy. Suppose any postmenopausal woman is on estrogen, she is fine, and one day she says, I have spotting, you have to do. Now it's completely gone. But now they are identifying a subsets where it is useful. There is a theory that is the progestin combination which was problem, that estrogen alone may not be. No. He showed that there was a 23% reduction in breast cancer when they were giving equine estrogen in the age group of 50 to 75. It's a medical paradox. Don't bother. He said apoptosis. So medicine is not easy. Right now, you are one hand, everybody knows it causes breast cancer, means it contributes to breast cancer, and you use anti-estrogen therapy. But there are a group of patients, the benefit was 23%. This study was done with conjugated equine estrogen. It's from the horse pregnant male. He concluded it may be due to some special product in the pregnant woman's urine, will estradiol. Now, right now, the only estrogen is estradiol. She started estradiol for the dysgenesis. So, he says these are paradoxes in biology. The last point I had, okay, now based on this data, that a subset of women can, the estrogen can be protective for breast cancer, you are contradicting the whole dogma. He says, this is not come as a recommendation. The guideline says, the recent, if you have a person who has a very low risk of breast cancer, very low risk of heart disease, if they are between 50 to 59 and they are 10-year postmenopausal, you can give estrogen. And it reduces breast cancer. If they don't, so you need to have some genetic say. So nobody is recommending breast estrogen as postmenopausal, but from the WHI study, they are doing subgroup analysis. A small subgroup may benefit. So it was 75 years of estrogen. Anupama, please come. Please come. Anupama, you have to come. So this finishes the estrogen. We are not going to do Kumar and Clark because this occupied a extremely important. See, you are prescribing. I think we need to wait till Dr. Sharada arrives. And Anupama, please. Okay, oh, one second. I'll just get the event going. Rajeshwari, please go there. Find out how long. There is no point starting until the crowd. My job is over. I have kept time, and I'm handing over officially to the event managers. But since they are delaying, I'll keep you entertained. Okay. Now one second. Please personally give a call to Dr. AST. Which part of Bangalore, which Silk Board Junction they have got called? Okay, one second. Excuse me. Anupama. Barli. One second. Sharda is on the way. Just call Tejaswini. Out of station, huh? Okay. No. Barli. Think of the devil like this. Okay. Now. Angel. Okay. Now, let the little bit of the crowd warm up. Okay. Now, one second. Please. Amma, the event will start. Kindly come. Only we do is, Amma, just go to the Gmail, download that G protein, and I will close it. Okay. Shila. No, 1 second. This one, I have to. No, Amma. No, I will answer any question. Please leave it to me. The last time there were some little doubts which I'm going to clarify. You tell me what's your question.
My question is a patient who does not have.
Please give it.
For a patient who does not have a uterus, this endometrial thing, why it will come when you give estrogen?
No, when there is no estrogen, when there is no uterus, no endometrium. They are not bothered.
Yeah.
That's why this patient, Reshma's patient with XY1 got only estrogen. She is not getting progesterone. I was worried. she doesn't have the uterus. She's going to review the literature. This, by giving only estrogen to a 17, 18-year-old or 20-year-old girl for next 35 years, I'm increasing breast cancer. By adding, so I'm concerned about the breast and the bone, nothing else.
No, estrogen is being given for what purpose?
For so many things.
Okay.
She is 21. It is giving, the 1 second, it is being given for all the beneficial effects. This girl, for a woman, it is being given for the brain, it is given, okay, the last point I said, he showed, 1 second, he gave a list of other beneficial effects. Do you know, estrogen had a function in reducing Alzheimer's disease. Estrogen has effect on neuronal growth, etc. He said estrogen has a role in behavior. And problems, OCDs can contribute if you have problems with your estrogen. It has effect on the cardiovascular system, immune system, role in puberty, role in menopause, role in skeletal muscle. So estrogen has a lot of effect on the woman. Estrogen is not endometrium in the uterus. So this lady should be the normal female. She will get estrogen till that 46 XY gonadal dysgenesis. She will get estrogen till she reaches the menopause age. For all the benefits, and don't be uterus centric. Estrogen is not for the uterus. Read other effects. Close.
Again, I'm not denying that fact, but doesn't have any other side effects.
No.
Because
1 second. We are replacing physiological estrogen. That's all. We'll take the question
Then
later.
why you give 21 days cycle like that?
That's why. No, because normally also in a woman's body, estrogen, you have to mimic normal physiology. Women's estrogen level goes up and goes down. You mimic normal physiology. That's all. See, even the breast, it may undergo sex. You have to mimic the nature's physiology. Myself and Reshma, we Googled, we'll take. It's a uncommon disease, but you have to do that.
Just one point. The same girl at age of 16 had some spotting.
No, that's don't distract. That is hematuria and or a vaginal injury. Close. No question. No discussion. Okay. This girl we presented who doesn't have a uterus, a lower 1/3 of the vagina, had some history of one episode of bleeding. It is not menstruation. She doesn't have uterus. She doesn't have upper 2/3. It's a local trauma or hematuria. Don't bother. Now we need to go forward, please. Illamma, you don't pray. This 1 second. Anupama, she has to bring all staff, including Madama and Maheshwari. The prayer will start when the support stops. It. Amma, bring Madama, Maheshwari. Everybody has to come.
She works with us in Vikram.
Wonderful.
So,
No, definitely. Okay. You are a full initial. Hexhe. Hafsa.
आगे है ना पीछे है ऐसा बनता है
HAFSA. Hafsa. Okay. Madam, sit.
This is Dr. Gautam.
Okay. Amma, 1 second. Ishama should be comfortable here. Amala il kursu atva she can rest. First kutkali. Inu shurvat takna karegi. Okay. Welcome the Queen of Honor. Banu, she has honored our request. All of you will take the blessings. Come. With the son. Son wants to be the mummy, please. Okay. She has come to give us the opportunity to take the blessing from the most active. Namaste. We will all take. Banu, we should get her a better footwear. Okay. She has come to all of us as part of this. We'll be touching her feet. That's the basic. 98, going strong. A very illustrious lady. Okay. Now, the proceeding will come, please. Dr. Gautami, part of the family she works in.
She will start working with us.
Wonderful.
So we have invited her in advance.
Wonderful. Okay. Now, excuse me, get all the support stuff, we will start. I want Raja, Prakash, everybody has to sit. Okay. Now, 2 things. Amma, just open the show. I will select this. Where is my? None tray become. Give my tray, complete my tray. No, that is your tray. This is my tray. Shh. Amma. Shh. Shh. Amma. Okay. I need little silence. Okay. Okay. Next Tuesday, I won't be there. Next Tuesday, the Sharda and team will conduct the class. Next, yeah, Kamala will manage with this one. Kindly provide silence. Next Tuesday is Madhumati's PhD first exam. So I'll be in, myself and Bamu will be there. And computer operators will also not be there. So next Tuesday, you conduct in whatever way you want to. You're free. And the coming Tuesday, we will be showing little bit about 10 minutes of a basic. All of you know small chemicals, aspirin, metformin as drugs. All of you know steroids as drugs. All of you know peptides as drugs, insulin, teriparatide, antibodies as drugs, monoclonal antibodies, PCSK9, cancer drugs, etc. There is a new area which has been touched upon in this 2-3 times called RNA therapeutics. 2 conditions. One, Prabha Clinic has a project where the VEGF injection to silence, it's called silence RNA. That is a totally new pharmacology which is slowly entering. Mr. Vinay Sima has showed twice. All of you know PCSK9 inhibitors have become a flop. It's only 1.5% reduction compared to statin. So for 8 lakh rupees, it is fell beyond the expectations. I sent you the article. Now they are trying a antisense RNA for ApoB. Last year he showed, this year he showed. He's hoping it will affect, but unlikely. Statins have done the maximum they can do. You can only get a cream. 10 minutes, Madhumati will tell 2 classes. As I'm waiting for Madhamma and Maheshwari. Amma, excuse me. Soumya has to come. Please don't hijack my operator. Please, Soumya. Okay, please. You are under my control. You have to be there. Come, sit there. No, 1 second. I will start the moment I see Madhamma, Maheshwari, Raja Prakash. Okay. Otherwise, every time they will be doing the garbage work and we sit here. Okay. Now, okay. Hari Om, 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 Hari Om. We wait for the support staff to come. Now, Amma, just show you. Last time, when we did the Kumar and Clark, you saw cell membrane receptors, you saw intracellular receptors. Intracellular receptors are cytosolic and nuclear. Cytosolic also enter the nucleus. Under the cell surface receptors, we saw the serpentine or the 7 transmembrane domain, and the number 2, the single transmembrane domain, single transmembrane, and they dimer also. These are the 2 mains. You saw the extracellular domain, transmembrane, intracellular domain. There was an issue of the G protein. We talked about cyclic AMP, adenyl cyclase, phosphodiesterase, etc. There was little, everybody got a message, but there are 2 finer points. I want to make it simple. There is a PowerPoint which we circulated to you, which we will show 2 days, because once you have started, you should understand it. You are going to come across diseases. Drugs like your theophylline are part of this system. So many common drugs. Your beta agonists, your salbutamol, everything works this way. Okay, if you want to know how it is working, we will discuss later. That PowerPoint has, okay, there are 3 things. You have a G protein coupled receptor, that is the serpentine receptor. Then the second complex is G protein, that has a alpha, beta, and a gamma subunit. Then you have effectors. Effectors are cyclic AMP pathway, inositol 3 pathway, and diacylglycerol pathway. And some G proteins is stimulatory, some are inhibitory. You learn whenever I see I use Githarol's phase as an indicator of how to do. I have to make it easy as a cartoon. So I will show you few things. Very, very simple. Just go back. 1 second.
Which one do you?
Okay, one second. I will start with this. Let me start with the simple one. Okay.
Open this.
No, 1 second. 1 second. I thought them. I want to open the simple. So open this. So I'll start with the cartoon. This is just to make, and 2 weeks from now we will tell you what are the diseases in which this involved. So you have to. No, this is alpha 2 beta. Proteocyclic is better. Alpha, beta, gamma, norepinephrine. Okay. See this. These are here. This is the 7 domain receptor. He has not shown the serpent. He has made the serpent as 1. This is the G protein coupled receptor. GPCR. These are the G proteins that has 3 units, alpha, beta, gamma, and this is one of the effector pathways. This is the enzyme adenyl cyclase, which converts ATP to AMP, cyclic AMP, then by phosphodiesterase, and the action comes. Similarly, instead of this, you can have IP3 pathway or diacylglycerol. They are all interstellar, and the same thing can be. See, this is a norepinephrine, epinephrine. Beta agonists are stimulatory. When they stimulate, this G protein is called gone. Where is the other one? Pointer. The good news is for those of you who didn't catch, we have a new projector. So the windows are open. It's otherwise people were sleeping. Okay, come. Sorry. Okay. You see, if beta agonist, that is the beta adrenergic receptor, it is stimulatory. When the G protein stimulate, you call GS. When alpha agonists are inhibit this pathway, you call it GI. So they have shown this cartoon. Okay. Okay. Like Bhagavad Gita, those of you who are in the group, once you know half-baked learning will create confusion. Show the next one. I'll tell you what to show. Okay. 1 second. I want to show this first. Show this. Now you got your serpent.
That is not possible.
With this.
I'll open now.
With this much better. Okay. Leave that. Okay. Now your serpent is back. I told you have to remember 3 things. The G protein coupled receptor, which is a serpent. Then the next unit is the G protein itself, alpha, beta, gamma subunit, which can be stimulated. And third is the effector. The most common is adenyl cyclase. You have the other 2. Now this explains why is it called G protein. Because it is the guanine nucleotide sequence. In the effector, you get cyclic AMP. So the reason it is called G is this G protein are associated with GTP, not ATP. ATP comes in the next step. So this is the serpentine receptor. Okay. See, 5 + 2, 7. Imagine adrenaline, norepinephrine, PTH binds to it. Signal is transduced. You have 3 subunits of the. This is the GPCR, G protein coupled 7 transmembrane. This is the G protein, alpha beta. This has GTP. GTP becomes GDP. GDP and binds GDP, activating the G protein. GS releases GDP and binds GTP. If GTP is bound, it is active. So it throws away GDP, takes GDP. Now the G protein becomes active. First is hormone binding, signal transduction, G proteins becomes active. The next step, this G alpha beta gamma, the alpha walks around. Out of the three, the active one, subunit separate. Once it separates, this subunit of alpha comes to adenyl cyclase. This is the last cartoon. So once G protein binds GDP, it gets its subunit separate. The alpha subunit, which has GDP, walks down, takes a walk, and then meets adenyl cyclase. So G protein subunits activate the target adenyl cyclase. Here you get cyclic AMP. So 3 steps involved. Okay. Then when it inactivates, then hydrolyzes, it's bound GTP to GDP and becomes inactivated. So once this GTP goes away, it comes back and reassociate. It continues close. This is enough. And there are diseases like in McCune-Albright syndrome, the G protein is constitutively active. There are some diseases which are due to mutation D receptor. Several drugs work through this hormone pathway that we will see later. Now I will hand over. Where is Madama? Where is Maheshwari? Where is Prakash? Where is Ramakrishna? Yen ಮಾಡ್ತಿದ್ದಾರೆ ಕೆಳಗಡೆ ಯಾರು ನೋಡ್ಕೊಂತಿದ್ದಾರೆ ಬಾಗಿಲು ಯಾರು ಬಿಟ್ಟು ಉಮಾ ಮೇಡಮ್ ಕೂತ್ಕೊ ಅವ್ರು ಬರ್ಬೇಕು ಅಲ್ಲಿ ಬಾಗ್ಲ ಕಳ್ಳೆ ಕ್ಯಾಮರ ಕೂರ್ಸು ಹಿಂದ್ಗಡೆ ಕೂರ್ಸು ಬೆಳಗ್ಗೆ ಹೇಳಿ ಬಂದು ಬೇಡ ಬೇಡ ಉಮನ್ ಕೂರ್ಸ್ಬೇಡ ಉಮಾ ಹ್ಯಾಸ್ ಟು ಕಮ್ Okay. But, you know, you will take care of the mark. Then once it's going. How do you get my
No. I don't want it.
okay, well, we had to
Correct. Thank you.
Okay, Amma, excuse me. She will hand. Only you go to the. Just minimize it. We are not starting this. Let it be also. You have to specially first bench can you go to the second bench? Don't do this. Don't do this. First bench na kare bench switch अब bench ಮಾಡಪ್ಪ ಆ bench ಆ ಕಡೆ ಇರ್ತಾರೆ ಸ್ವಲ್ಪ ನಿಂತ್ಕೊಳ್ಳಿ ವಿಜಯ ನಿಂತ್ಕೊಳ್ಳಿ ಒಂದು ನಿಮಿಷ ಹಾಗೆ ಯಾರು ರೆಡಿ
So, good afternoon, dear all family members. So happy to have you all on this auspicious day. So, I request Dr. Doctor and her team to start today's auspicious day by invoking the presence of Lord. Can we start? It is all being recorded.
recorded live and broadcast world over.
Thank you. Namaste. Good morning to you all. I am Shada and this is my little friend from Indranagar. None of us are professional singers. So forgive us and may Lord forgive us for any mistakes we make in Swara, Tala, anything. We are just praying to God because once again I remind everyone in the audience, forgive us for any mistakes in the Swara or Tala. This was about team effort. None of them even know Sarigama, Padanisa or Sarali Varsa. So we have sincerely tried to put this prayer together. This is Ramanamamu Janma Rakshaka Mantram. This is Tyagaraja Kriti. Tyagaraja, as all of you know, he is a saint and poet who created all songs in Telugu, which is called Telugu Tena. Telugu Tena. Tena means honey. Telugu is the language which is as sweet as honey. So we have chosen this language. And Tyagaraja, as all of you know, has spent his entire life praising Lord Rama. So this is in praise of Lord Rama. And music knows no language but the language of love. And with love, we submit this to God, to fellow human beings, our teachers, our colleagues, our patients, and our near and dear ones at home. Thank you. So we will start now. Janma Rakshaka Mantram Tamasamu Chiyata Vajimvade Manasa Ramanamamu Janma Rakshaka Mantram Tamasamu Chiyata Vajimvade Manasa Soma Surya Netrudaina Soma Surya Netrudaina Ramachandruniki Sariyavare Ramachandruniki Sariyavare Ramanamamu Janma Rakshaka Mantram Tamasamu Cheyata Bhajimbave Manasa Kamamoti Rupa Ramachandra Kamita Palada Ramachandra Kamagoti Rupa Ramachandra Kamita Palada Ramachandra Dhyana Swarupa Ramachandra Dhyana Swarupa Ramachandra Rama Rama Dhyana Swarupa Ramachandra Tyagaraja Chita Ramachandra Tyagaraja Chita Ramachandra Ramanamamu Janma Rakshaka Mantram Tamasamu Cheyata Bhajimbave Manasa
Thank you very much, thank you so much, madam, for the melodious song. Now I will request Soumya to start the next proceeding, Spirit of Samarpam, silent slideshow.
Next slide, please. Next slide, please. Lot of effort is on.
Dear family, let us reminiscence in the next few minutes. Spirit of Samatvam, service with devotion. In a recent article, Dr. Stephen Swenson of USA in NEJM article, he has mentioned about Esprit de corps, that is, spirit of the body. In the heart of every high-performing organization are joy-filled teams. You will not find a high-performing organization without Esprit de corps. Esprit de corps is the spirit of the body. Camaraderie, engagement, and passion interwoven with joy. It is the single most important leading indicator over which we have control of patient experience, patient outcomes, patient safety, and patient costs. Now, let's talk about Pando tree. Pando is a group of more than 40,000 quaking aspen trees that share a single root system estimated at more than 80,000 years old. This is Esprit de corps. It's the connectedness, the trust, the camaraderie, the fulfillment, the passion, and the loyalty of people to each other, and most importantly, to their mission. If we want to become high-performing organizations, we need to learn from the highest performing organism on planet Earth. This is the Pando tree in Fish Lake National Forest, USA. Pando means to spread out. Though it looks like a forest, the whole thing is actually a single organism. Every tree or stem technically is genetically identical, and the whole forest is linked by a single root system. Pando's aspens reproduce asexually by sprouting new stems from the root structure, with over 40,000 stems and a weight of 13 million pounds. The Pando clonal colony is the heaviest known organism in the world. It's also amongst the oldest living things on the planet. The root system is estimated 80,000 years old. This is a single tree. Our journey began in New Delhi, India in 1987. Now, Samatvam moved to South Bangalore, India in 1994.
I'll share that. Next. Okay, just go back. Please, excuse me, don't make any arrangements, come and watch. All of you go back.
No, somebody had entered the place where we get everything.
Okay,
So we have
okay, no, just go to the first one and bring it back. Go. Go back. Hey, it's for done for you. Done. The other one, the first one. Bangalore. Start from Bangalore again. Bangalore, go to Bangalore. Go back to Bangalore. Move south. Move south. Go back and start. Restart. Previous one. Let's start with this one.
Yeah, this is an ongoing project, and we would be filling every page with all the details by the next 6 months.
One point, this is the legacy. The first part is called the programs. So this is going to build up in the now India's independence, Sepoy Mutiny, Quit India movement, everything. The first portion will be done by Ashwini and there are more than 1 lakh photographs. They have built a story. The first portion will be done by Ashwini and Kavita. The second portion, you people have to tell your stories. That means Sharda, everybody has to submit. Geeta has to submit what is the best moments, happy moments, achievements in that. When you give, your chapter will be added. for everybody. So these are blank because they did get the photos. You send the photos, how you came to the temple, how it was useful. So it is an incomplete book. The next one will be next year. By next 6 months, you send your PowerPoint, they will organize. Okay, go ahead. Yes. And then how? Shruti, not can come? Where is Praveen? Namaste. So she is part of the family. They want to pray for you and be with us for an hour and make yourself peaceful. Second upper row. He's the Mexican man. Tiananmen Square. This is Olympic field. The mustache fellow, forehead. Forehead, only. Desert safari. Miracle Garden.
Henry Ford said, "Coming together is a beginning, keeping together is progress, working together is success." And the journey continues. Thank you.
Don't go. Shuchi and Praveen. Shruti, sir, please. Come. Anupama, take over. Anupama. Mama. Mama, please. Anupama. Vijay. Bless them. This whole program is being broadcasted live. Okay. And it will be recorded. So you have to speak to the microphone.
Shruti, Ganapati and Praveen recently got married. We were so much wanted to go to the marriage, attend, but due to the stress, we were not able to go. So congratulations. God bless you. God bless you. Really missed your marriage. We wanted to come in.
We like the lamp. Swamiji, like the lamp. Go, okay.
No, Swamiji is lighting the lamp. So Asato ma satgamaya Jyotirgamaya Mrityungamaya Om Shanti Shanti Shanti.
Shruti, ಕೂತ್ಕೊಳ್ಳಿ. Please, Praveen and Shruti. Swamiji, 1 minute. Give the Vijay. This is being broadcast, so she's okay. Swamiji, bless the young couple. Then we'll have the Guru Vandana. Just blessings for the young couple.
So, Hari Om. It's nice to have a newly married couple with us. And as I heard from her that in the marriage, of course, could not attend, but I think this is the best occasion to get the blessings, not only from few what they would have done. So all elders here, me, all my best wishes, blessing for thank you.
Come on, call, do the honors. Lakshmi, come. Anupama. One second. Anupama. Come. Nirvama. What's the next day? It's okay. I'll shout. Now, next 10 minutes, anybody can come and tell their reminiscences. Then, in last one, please, Swamiji. So, anybody, I'll start with Sharada. Sharada and Kamal. Okay, yeah, speak to me. Can you see the mic? Okay. Just 2 words. That will be the last one. Then we disperse. Okay. That's the last one. Please come. That will be a serious one. Kamala. Where is Kamala? Come. In the next few minutes, reminiscences. Anybody can come to the stage and share your feelings, followed by Hitavachana of Swamiji. This is now, anybody can come to the stage and it's open house. Then Swamiji will do Hitavachana on Guru Purnima and Guru Vandana. The last item, we have the greatest privilege of having Shri Rangamma Baludev Mahadev Bhatt, Shri Rangamma Mahadev Bhatt, Balu's Holy Mother. At the end, she'll be here. She is 98. Balu will introduce his body himself, and you can touch the feet, get the blessings of this 92-year-old Saint Mother. Then we pray for the potluck and the group prasad on the side. Now, please come. It's open. Anybody come up? Okay, go ahead.
So, I'm very excited. Good morning to everyone. And Gundaman has asked me to speak. I have not had to speak. So, I am always listening to Gundaman. And I am speaking again. So it was not on, no? That was not my problem. Okay. So, I am speaking here because Gundaman requested me to speak through Soumya. So, the journey so far, I always wanted to be a good doctor. That was my only aim in life. I was trained in Carnatic music for 5 years from 1st standard to 5th standard. But my love was not just singing songs. I was put in Kalakshetra almost, which is the best Bharatanatyam dance training institute in India, in Tamil Nadu. I retraced my steps from the admission center saying I want to be a doctor. So my only aim was to be a doctor. Why I am saying this? And then I was getting married to my husband, Dr. B.A. Mahesh. His cousins asked me and his Dodapa asked me, what do you want to do? I had already completed my MD. I said, I don't care what I do. I want to be the best at it. I don't mind being the doctor for the little finger of everyone, but I want to be the best little finger doctor in the world. And then I met Gundaman, Dr. Shrikanta, and I felt he is the definition of a doctor. And that is how we got associated. Wonderful. So Gundaman in my dictionary will remain for the rest of my life the definition of a doctor. Because he has that ability to concentrate, to persevere, to go till the end and find what's wrong with the patient and then treat it. Suppose you are unlucky and he doesn't concentrate on you, that is your bad luck. Otherwise, having said that, if you are very lucky, most of the times, 90% he will concentrate, he will do the best that is possible anywhere in the world. So that is why I am associated with Samatvam, and I have had my dream. Unfortunately, endocrinology and diabetes is very huge. It is not a little finger. I have to deal with so many different glands and so many different problems, but that keeps me very, very active in my brain. When I went to England, I had an interview with a lady which I didn't understand I was being interviewed. Paul Belschitz, my boss, said, Anna wants to speak to Shada. Can you have a word with her? How am I supposed to know it's an interview? So I went there and she asked me, it was an interview for the job, which I thought I have already got, but it was supposed to, I was supposed to pass that. And she asked me, why have you become a doctor? I said, I am like Sherlock Holmes. I love Sherlock Holmes. I want to have the small clues and get there and find the diagnosis and then treat the patient. Do the right test, get the right answers, and then get there and treat the patient. And so I got the job because of Sherlock Holmes. So it was a very good journey in England. I went to England courtesy Gundaman and Dr. A.S. Irving. So the journey so far has been very, very eventful. I will not say it's always smooth. No relationship, no journey is all like how they show in movies or in fairy tales. They live happily ever after. In all relationships and all institutions, there will be good and bad. And by and large, we stand with each other during good times and bad times and continue to serve the people, the patients, and our loved ones, and our extended family. And that is the spirit of Samatvam, the love for fellow human beings, and to serve them with devotion. Thank you.
Sir told next is my turn. I joined Samatvam in November 2003. Though I came to Bangalore in November 1993. 10 years after that, I came to know this. Through Dr. Lakshman, I joined. Since then, I can proudly say I never was absent for more than 3 or 4 days in my 15 years of career. So I am always present, more related to JNANA Sanjeevini rather than Samatvam, because this center opened in September 2003, and I am the first doctor to come here along with one staff member, doing all-in-one job, starting from looking after the medicines, prescription, billing, lab, all those things. Now from that stage, we have come to this stage where it has become a big institution, and we are all growing along with that institution. I thank everybody for this. Mainly Dr. Srikanta for teaching us so many learning points, not only in the subject, but also in the life attitudes. And this will grow further. Thanks a lot.
Dr. Jailakshmi joined in February 2017. And just tell in 2 words, that whenever, weekly one time I come to JNANA Sanjeevini Samatvam. Whenever I come here, I feel very comfortable and very peaceful.
Misbehavior started already.
We have same time, so we want as many people to come.
Hello, I'm Vasanta Lakshmi. I'm a counselor here. Mine is a long story. When I finished my BSc, I wanted to become a doctor. Actually, I have applied for Bangalore Medical College along with my cousin, Dr. Arun. But I couldn't get the seat. Sometimes my brother tamashi ಮಾಡ್ತಾನೆ ಎಷ್ಟೋ ಜನ ಬದುಕೊಂಡ್ರು ನೀ ಡಾಕ್ಟರ್ ಆಗ್ತಾ ಇರೋದಕ್ಕೆ ಅಂತ it's okay but ಇದು ನನಗೆ ಇದೇ ಇತ್ತು but I joined Canara Bank as a clerk. I did my 30 years of service in Canara Bank and I took voluntary retirement 8 years service ಇರುವಾಗ but 2002 was my turning point actually. I lost my husband. I thought everything is over, but ನನ್ನ cousin Usha, ನಿನ್ಗೆ ಎಷ್ಟು ನಾಲೆಡ್ಜ್ ಇದೆ, ನಿಂಗೆ ಓದೋ ಆಸೆ ಇದೆ, why don't you join Samatvam, ಅಲ್ಲಿ ಕೌನ್ಸಿಲರ್ ತರ ಕೆಲಸ ಮಾಡು ಅಂತ. ನಾ ಹೇಳ್ದೆ ನಂಗೇನು ಅದ್ರ ನಾಲೆಡ್ಜೇ ಇಲ್ಲ, ಇಲ್ಲಿ ಬಂದು ಸೇರ್ಕೊಂಡು ನಾನು ಏನ್ ಮಾಡ್ಲಿ ಅಂತ. ಇಲ್ಲ ಅಂತ ನಂಗೆ ಗೊತ್ತಿರ್ಲಿಲ್ಲ. ಡಾಕ್ಟರ್ ಶ್ರೀಕಂಠನ್ ಚಿಕ್ಕ ವಯಸ್ಸಲ್ಲಿ ನೋಡಿದ್ದೆ, ಆಮೇಲೆ ನೋಡೇ ಇರ್ಲಿಲ್ಲ. ಡಾಕ್ಟರ್ ಶ್ರೀಕಂಠ ಅವ್ರದ್ದು ಅಂತಾನು ಗೊತ್ತಿರ್ಲಿಲ್ಲ ನಂಗೆ. ಬಟ್ ಅವ್ರಿಗೆ ಫಸ್ಟ್ ಟೈಮ್ ನೋಡುವಾಗ ನಾನು ಹಾಯ್ ನೀವಾ ಅಂತ ಕೇಳಿದೆ ನಾನು. ಅವ್ರು ನನ್ನನ್ನು ಚಿಕ್ಕ ವಯಸ್ಸಲ್ಲಿ ನೋಡಿದ್ದಾರೆ, ಜ್ಞಾಪಕ ಇಲ್ಲ. ಆಮೇಲೆ 2003 ಏಪ್ರಿಲ್ ಅಲ್ಲಿ ಐ ಜಾಯಿಂಡ್ ಆಸ್ ಎ ಕೌನ್ಸಿಲರ್ ಅಲ್ಲಿ ಯಡಿಯೂರ್ ಬ್ರಾಂಚ್ ಅಲ್ಲಿ. ಅಲ್ಲಿಂದ ಉಮಾ ಆಮೇಲೆ ಉಷಾ ಕೆಲವರಿಂದ ಟ್ರೈನಿಂಗ್ ಎಲ್ಲ ತಗೊಂಡು ನಾನು ಬೈ ಪ್ರಾಕ್ಟೀಸ್ ನಾನು ಎಷ್ಟೋ ವಿಷಯಗಳು ಕಲ್ತ್ಕೊಂಡ್ರೆ. ಐ ಹ್ಯಾಡ್ ದ ಅಪರ್ಚುನಿಟಿ ಟು ಅಟೆಂಡ್ ಇದೆಲ್ಲ ಕಾನ್ಫರೆನ್ಸ್, ಎಷ್ಟೋ ಡಾಕ್ಟರ್ಸ್ ಅವರ ಲೆಕ್ಚರ್ಸ್ ಎಲ್ಲ ಕೇಳೋ ಅವಕಾಶ ಸಿಕ್ತು. ದೇವರು ಹೆಂಗೆ ಟರ್ನಿಂಗ್ ಪಾಯಿಂಟ್ ಮಾಡ್ತಾನೆ ಅಂತ ದಟ್ ವಾಸ್ ಮೈ ಪ್ಯಾಷನ್. ಡಾಕ್ಟ್ರೆ ಇದು ತಿಳ್ಕೋಬೇಕು ಅಂತ ಅಂದ್ಬಿಟ್ಟು ಆ ತರ ನಾನು ಎಷ್ಟೋ ಜನರ ಸಹಾಯದಿಂದ ನಾನು ಈ ಮಟ್ಟಕ್ಕೆ ಬಂದಿದ್ದೀನಿ. ಬಟ್ ನನ್ನ ಮಗಳ ಮದ್ವೆ ಆದ್ಮೇಲೆ ಸ್ವಲ್ಪ ಇರ್ರೆಗ್ಯುಲರ್ ಅಟೆಂಡೆನ್ಸ್ ಶುರು ಆಯ್ತು. ಯಾಕೆಂದ್ರೆ ಮೊಮ್ಮಕ್ಕಳನ್ನ ನೋಡ್ಕೊಳ್ಳೋದು ಅದು. ಇವಾಗ ನಾನು ಐ ಆಮ್ ಗೋಯಿಂಗ್ ಫಾರ್ ಎ ಲಾಂಗ್ ಲೀವ್. ಐ ಗಾಟ್ ಮೈ ಪರ್ಮನೆಂಟ್ resident of Hong Kong, so I'm leaving on 22nd. So I'll be back in December, and 1 year I can stay there, and after that 3 years ಆ ತರ ಇರುತ್ತೆ. ಇವಾಗ ನನ್ನ ಮೊಮ್ಮಕ್ಕಳಿಗೆ ನನ್ನ ಅವಶ್ಯಕತೆ ಇದೆ, ನನ್ನ ಮೊಮ್ಮಗನೂ ಬಂದಿದ್ದಾನೆ. ಸೊ ನಾನು ಯಾವತ್ತಿದ್ರೂ ಇಲ್ಲಿ ಬಂದಾಗ ಫ್ರೀ ಆಗಿರುವಾಗ ಐ ಗಿವ್ ಮೈ ಸರ್ವಿಸ್ ಟು ದಿಸ್ ಇನ್ಸ್ಟಿಟ್ಯೂಷನ್. ಮರೆಯಕ್ಕಾಗಲ್ಲ, ಇದೆಷ್ಟು ಫ್ಲೆಕ್ಸಿಬಲ್, ಈ ತರ ಫ್ಲೆಕ್ಸಿಬಿಲಿಟಿ ಬೇರೆ ಎಲ್ಲೂ ಸಿಗೋದಿಲ್ಲ. ಕಲಿಯೋಕೆ ಬಹಳ ಇದೆ ಇಲ್ಲಿ. ಕಲ್ತ್ಕೊಳ್ಳೋಕೆ ತುಂಬಾ ಇದೆ ಈ ಇನ್ಸ್ಟಿಟ್ಯೂಷನ್ ಅಲ್ಲಿ. ಎಷ್ಟು ಡಾಕ್ಟರ್ಸ್ ನ ಎಷ್ಟು ಇದರಿಂದ ಪ್ರೋತ್ಸಾಹ ಮಾಡ್ತಾರೆ ನಮ್ ಡಾಕ್ಟ್ರು. ಆಲ್ ಥ್ಯಾಂಕ್ಸ್ ಟು ಡಾಕ್ಟರ್ ಶ್ರೀಕಂಠ. ಥ್ಯಾಂಕ್ ಯು ವೆರಿ ಮಚ್.
VM Lakshmi physician wants to have a word with all of us.
Hello. Yeah. So my first connection with SANJEEVINI was through Sharda. Sharda and I were, colleagues in Manipal Hospital. And when we left Manipal Hospital almost together, she started with Dr. Shrikanta. And she used to keep telling me whenever we met, it's really good. She used to be so animated. And I used to be always thinking, okay, someday I have to come here. And along the way, whenever I started interacting with Dr. Shrikanta, the first thing that used to be like, he used to ask some question. And the moment he asked the question, I used to be, very beautiful. Then you know the answer was amazing. His questions, the ability to ask the right questions, to focus on where you need. I think that is something amazing. And the journey here for me has been really, really good. I feel very blessed and graceful.
First time try.
ಸರ್ ನಂಗೆ ಏನ್ ಮಾತಾಡ್ಬೇಕು ನನ್ಗೆ ಏನು ಗೊತ್ತಿಲ್ಲ. ಬೇರೆ ಮಾಡ್ಕೊಳ್ಳಿ. ಯಾಕೆಂದ್ರೆ ಯಾರೋ ಒಂದು ಹಳ್ಳಿಯಿಂದ ಬಂದಿರೋದ್ರ ಡಾಕ್ಟರ್ ಕಲ್ತಿರೋ ಇಷ್ಟ ತುಂಬಾ ಇದೆ. ನಾವು ಮಾತಾಡಕ್ಕೆ ಏನಕ್ಕೆ ಬರಲ್ಲ ಬಾಯ್ ಬಿಟ್ಟು ನಮ್ಗೆ. ಅಷ್ಟು ತುಂಬಾ ಇಂಪ್ರೂವ್ ಮಾಡಿದ್ದಾರೆ ಎಲ್ಲಾರು. ಪ್ರತಿಯೊಂದು ಕೆಳಗಿಂದ ಒಂದು ಪೇಷಂಟ್ ಡಾಕ್ಟರ್ ಬರಲ್ಲ, ಪಕ್ಕದಲ್ಲಿ ಪೇಷಂಟ್ ಕೂರ್ಸ್ಕೊಂಡು ಡಾಕ್ಟರ್ ಮಾಡ್ತಾರೆ ಇವತ್ತೊಬ್ಬರು. ಅಲ್ಲಿ ಏನ್ ಹೇಳ್ಬೇಕು ಅಂತ ಗೊತ್ತಾಗ್ತಿಲ್ಲ ನಮಗೆ.
He is a founding member of Samatva.
ಏನು ಓದಕ್ಕೆ ಇದು ಏನು ಗೊತ್ತಿಲ್ಲ. ಬಟ್ ನಮ್ಮ ಡಾಕ್ಟರ್ ಸ್ವಲ್ಪ ಮನ್ಸು ಮಾಡಿದ್ಕೆ ನಮ್ಮ ಮಕ್ಕಳು ಇಂಜಿನಿಯರ್ ಆಗ್ತಾರೆ. ಅದು ಖುಷಿ ಪಡ್ತೀನಿ ನಾನು. ನನಗೆ ಓದಕ್ಕೆ ಏನು ಗೊತ್ತಿಲ್ಲ, ಆದ್ರೂ ಎಲ್ಲ ಏನು ಗೊತ್ತಿದ್ದೆಲ್ಲ ಟೀಚ್ ಮಾಡ್ತೀನಿ. ಅಷ್ಟೇ ಸರ್ ನಾನು ಹೇಳೋದು.
Only 5 more minutes left. Come, Veena. Don't only 5 minutes. Then Swamiji will talk quickly. 2 lines, whatever you feel.
I've been associated with Samatvam for 17 years. It was in 2001 that I met Madam at the Indiranagar Center. And the first thought that came in my mind is this is a place which will help me to grow, learn. And yes, I'm a very different person than what I was in 2001 September. Madam will know it. Thank you.
Hello everyone, I'm Dr. Chandrika. I've been here maybe around 11 years or so, 2007. I was doing my fellowship with Narayana. That's when I got introduced to Sir. My mentors there were Sir students, and then I left Narayana and I joined Sir. And ever since I've been here, I've been to all the centers, Samatvam, SANJEEVINI, Indiranagar, all over. I like the first thing Sir does is whenever he meets anyone, not for the first time or second, anytime, he sits with a paper and starts writing, yes, what do you want to do? What is your goal 5 years from now, 10 years from now? That's very impressive, and I think I've adopted a lot of his characters, many things, especially in problem solving. I've had many difficult situations. He's always brought me out of it, and I'm very, very thankful to him. Yeah, he sent me to Jocelyn, he sent me to Mayo. That's academically. But personally, even in my life, he's played a major role as a mentor, guide, philosopher, everything. He's all in one for me. Thank you so much.
I came here in 2009, broken in spirit and body. And you know what Dr. Shrikanta did to me? He primarily kindled the joy of learning in me. He again made me enjoy what I had already enjoyed in life. And I rapidly absorbed lots of medicine. And that was not just that much. Also, the international tours that we went on, it was the best part of my life. Whether it was Dubai or Beijing, or wherever it was, even the domestic conferences. And in Dr. Shrikanta, I found a personality that was truly in love with his patients and humanity. His self-service to raise and uplift the deprived is indeed something wonderful. And as a doctor, he is the best. He is somebody who can look through you transparently and find out what's wrong with you. That's nowhere in more focus than in me, because I used to imagine I had something incurable. But the way he handled me by telling me that there was nothing wrong, that is testimony to my even alive at this point in time without doing more harm to myself. Hats off to Dr. Srikanta, Samatvam, and all of you. Thank you very much.
We'll just stop in 5 minutes and Swamiji will go to Guru Vandana, and then we go for the prasad. The meeting will be over, then you can interact. 1 minute, please.
Yeah, thank you very much, Dr. Srikanta. I'm really stunned. I'm not meant
Sir, one second. Sir, I have got only request. The remaining speakers should not speak about Srikanta. Yes. Okay. It's bad. It's already over. No, that is one thing I'm very serious. Not about the institution, not about me.
I'm really stunned. I'm not meant a great genius and Dr. Srikanta and all that. So, what which Dr. Prasanna spoke now, he spoke so correctly. He's a selfless man. He's the chap who does such a lot of publications. He doesn't get his name either in the beginning or the end. I've never seen an author paper giving it to his students to write. These are the special qualities. He's humble. He is learned. He is kind. He is a holy man, and he believes in God, which I don't believe. But selflessness is the most important hallmark of this. Generosity to the extent that is really unbelievable. He earns for other people. He doesn't earn for himself. He's taught me a lot of things. I'm privileged to be here, and I've probably known him for the last 17 years. In 2001, I first met him, and I salute him. But about Samatvam, the way he has brought this place forward, he struggles a lot. He's a bad administrator, let me tell you that. He's a bad administrator. He doesn't know what happens in the account departments. He doesn't know where the money goes or where the money comes. He does not get a grip on things. He could have built a hospital here by this time. But he is more devoted to education, teaching, and research. And there is where he falls. And if only he could do that also just as well as he does the teaching, we would all be seeing a big hospital here by this time. The other thing I wanted to say was he has brought so many people forward education-wise. He should also have been able to get a professorial job in Bangalore, which is richly deserved. Somehow or the other, that has not happened. And so he didn't want everybody to praise him. I've now criticized him. I salute Dr. Srikanta once again. I'm honored to be at Yeah.
He will not allow the patient to come. He is Sharda's best friend. Shardan jothe Samatvam jothe ಕೆಲಸ ಮಾಡಿದ್ದೀನಿ ಏನು ಅನ್ಸಿದೆ ಜಗಳಕ್ಕೆ ತರ ಮೇಡಮ್ ಜೊತೆ ಇಲ್ಲ ಅಲ್ಲ
18 ವರ್ಷ ಆಯ್ತು. ನನಗೆ ಮೇಡಮ್ ದೇವ್ರು.
ಜ್ಞಾನಸಂಜಯನು ನಾನು 18 ವರ್ಷ 3 ವರ್ಷ ಬಿಲ್ಡಿಂಗ್ ಕೆಲಸ ಮಾಡ್ದ. 15 ವರ್ಷ ಹಾಸ್ಪಿಟಲ್ ಕೆಲಸ ಮಾಡ್ದ.
Okay.
ಸಿಂಪಲ್ ಆಗಿ ಹೇಳ್ತೀನಿ, ನನಗೆ ಒಂದು ಮನೆ ಇತ್ತಂದ್ರೆ ಇದೇನೆ ಸಾಕು. ಐ ಲವ್ ರಿಯಲ್ ಬ್ರದರ್. ವಿ ಆರ್ ಸ್ಕೇರ್ಡ್ ಈಚ್ ಅಂಡ್ ಎವ್ರಿ ಟೈಮ್. ನನ್ಗೆ ಏನ್ ಕಷ್ಟ ಆದ್ರೂ ಒಂದ್ಸತಿ ಫೋನ್ ಮಾಡಿದ್ರೆ ಸಾಕು.
Swami is waiting. These are Rajeshwari and Sumati Madhya. Please, and you go. Swami is waiting. Come. Sumati, come.
Hello. Yes, call my name. My name is Geeta Rao. I've been working here for quite a long time, 12 years and odd. Everybody has spoken about Dr. Srikanth so much that you all know he has so much of positivity. In a simple word, this building is more than a temple, and I have personally seen people who have come with problem and joined this place, their problems have been solved, and that positivity is because of this person only. And that's all I want to say. Next place to work.
Come on, Rajeshwari, and it will be concluded by Sumati Madhya.
Hello. 15 years in the contract. So,
ಡಾಕ್ಟರ್ ಅಂಜಲಿ ಮೇಡಮ್ ಕಡೆಯಿಂದ ನಾನು ಬರ್ಬೇಕು. ಡಾಕ್ಟರ್ ಅಂಜಲಿ ಮೇಡಮ್ ಕಡೆಯಿಂದ ನಾವು ಬರ್ಬೇಕು. ಅವತ್ತಿಂದ ಇವತ್ತಿನವರೆಗೂ ಏನ್ ಕಲ್ತಿದೀವಿ ಅದಕ್ಕೆಲ್ಲ ಕಾರಣ ಸರ್. ಮತ್ತೆ ಇದು ಓನ್ಲಿ ಅಡ್ಕೋಸ್ಕರ ಇದೆ, ಅದಕ್ಕೋಸ್ಕರ ನಾವೆಲ್ಲರೂ ಈ ಸೋಷಿಯಲ್ ಕೆಲಸ ಮಾಡ್ತಾ ಇದ್ದೀವಿ.
Well, okay, we'll make personal interest. Swamiji will start the statement, please. Speak. You are being recorded. Please speak.
Thank you very much for this privilege.
Near your mouth.
I feel my words are very less to express what exactly I feel here. Excuse me, sir. In Tamil, I want to say one word. எழுத்தறிவித்தவன் இறைவனாவான். It means the person who gives you knowledge is nothing but God, and I really thank God. I was referred by Madam, and first time when I met sir, he said, "You have worked so long. I have been in a government job, working abroad." And then they said, "Why are you here? What do you want to do?" I said, "Sir, I want to give the best to my patients. That's all. I don't have anything more." Then he said, "You want to get the best education or about diabetes, you will learn the best in the world." And he referred to my mother. And really that's true. I think I have been a different person in every day after being with her. And I cannot miss saying this. The same words, I was diagnosed with cancer. Then sir said, "I will give you the best treatment in the world." And that's how I think I'm surviving here. And both madam and sir, I think I was going up a little back. I should say this. And the other part of it is, what is Samatvam to us? It's just like an eagle. It takes us up and throws us down and flies down that we don't fall down. This is exactly happening every day with each one of us. I think everybody should agree my word. Madam literally dragged me to the hospitals. And it was literally, I was forced to go to the hospitals. And now I find my place somewhere. And it's all because, even now this singing, I think I've never sang in my life. The first time, see, the Guru is what? Who recognizes your capabilities and then brings it out. So that's exactly happens here. So how much we have evolved, I cannot explain in every form, not only in medicine, but in spirituality, in every way, and with love. I think what they explained about the red vines of the tree, I think all of us, I think I am more privileged to be the best connection. My roots are very, very well intertwined here. each one has given their roots to me here. I think I am the most privileged of all here.
Okay.
Gurubhyo Namaha. Guruve Sarvalokanam Vishajay Pavaroginam Nidaye Sarva Vidyanam Dakshina Murtaye Namaha. Harihi Om. I came to this holy place, transformed it into a temple in 2011. I came straight from Hyderabad after working there for about 37 years. And when I came here, I just came with a plea that I should work as a counselor here. Maybe he thought I was unfit to work as a counselor, so he put me into administration. He said, take care, whatever best that you can do, please do it. So we tried to do something, but it's not, I don't think I had done it to his satisfaction. But whatever it is, the temple has grown into a beautiful place where I see so many people working with service with devotion is the most important thing which he coined, and that's the preamble of this institution. And I think everybody deserves kudos for that. And I wish all the staff a very happy, prosperous, healthy, and long life. Thank you.
We have requested. You want first? Why do you want to sit up? You want to stand? Okay. Okay. Well, just one thing before Swamiji starts. I request Dr. Foundation is knowledge. I got 2 copies of Kumar and Clark. Okay, to each of the institutions, I request Dr. Arthanarishwari Sharada to come and receive. This is the foundation of clinical medicine. Kumar and Clark. I want Dr. Chandraprabha Siddhalingappa to receive a copy for, they have brought one for each team of the JNANA group. She has the biggest office. She has to sit and read. This is the copy for the JNANA one. Now, Tejaswini has not come, so this is for the Samatram BPM layout. We'll give it later. And this
wants to take it for the
okay. This is this is BTM. We have 2 branches in BTM. BTM 1, BTM 2. BTM 1 is her and BTM 2 is her. BTM. This is for BTM 1. Please read every line of it, every word of it. Now, we need a Samatvam cantonment. It has to come. Lakshmi Reddy will come and receive her. She has to set it up. Samatvam, see, Samatvam.
Jayalakshmi is asking about Jnana.
No, that will come last. And next time she will get Samatvam Receptor member also. Okay, the last one. Okay, I would like Dr. Kumar Kamala to come and receive Swamiji, one request. Guru Vandana Guru Vachana. Then I would request you to complete the program also. Purnamadam, everything. Then Swamiji will officially close the function. Before that one, then the mother will sit here. We take her blessings and proceed for the prasad. Just introduce your mother for 1 minute before Swamiji gets done. Because the event will be over with this close. He will introduce the Holy Mother.
Hello. I'm really lucky to have my mother with me for all these years. She's been a good mother. She didn't hit me, but she used to pinch me now and then. And she said, if I ever catch you, I'll skin you. Apart from that, she has not harmed me. Why I'm so lucky is, not only is she physically fit and totally independent, but she's also mentally 100% sharp. She's still the walking encyclopedia in our house. She's a reference point. I can ask her anything about the past or the present, and she can tell us quite accurately what's happening. So with that, I don't want to say more. It's just that I'm blessed because I have my mother.
One comes from an illustrious family. Many of you know, just for a revision. 3 people started yoga. They went up north and learned from Krishnamachari. Sri Krishnamachari. They were B.K. Sayangar, who institutionalized. Second one was Pathavi Joyce. The third one was Mahadev Bhatt. Mahadev Bhatt didn't institutionalize, but taught yoga in the Mumbai area. Then Srimati Rangamma Mahadev Bhatt is the world's first accredited women yoga teacher, and she was decorated by none other than the Maharaja of Mysore, who told her, as a woman, spread the knowledge. And that is the mother-son relationship. She said 98, and after the event is over, I request, the purpose is take her blessings so that the generations to come would do. Now, Swamiji will conduct the pravachan, and he will also close the meeting. You will do their own listening. Thank you.
Om Sadashivasamarambham Shankaracharya Madhyamam Asmadacharya Paryantam Vande Guru Paramparam. So, first of all, I am very happy to be here today with the journey of a Samatva. And it is a really wonderful journey. As last 15 years, I myself have been the part of this Samatvam journey, associated most of the people here who are all serving, and therefore it's a wonderful, too happy to be associated, and it is always my privilege. Now we don't have much time. The doctor has given me the area to deal. So Guru Vandana. And then in between, he gave me some hint also that I should be serious. So, because he said that Swamiji will talk serious. So therefore, definitely I have to be serious. It's a very nice, we can say, the spirit we have got, a Guru Vandana. The before understanding a Guru Vandana, I think we must understand that who can be a Guru. And as that lastly, I don't remember now her name, the doctor, she said, that's nice, she has defined nice way, that whoever gives a knowledge is a Guru, is a Deva, the God. And generally we have got the Guru Brahma, Guru Vishnu, Guru Devo Maheshwaraha. So in this spirit, if we try to understand the Guru or Guru's role, then going back to our Upanishad, the Vedic tradition, and we find there are a nice capsules, 4 capsules, most of us being exposed to the culture, we know that. And that is a Matridevo Bhava, Pitridevo Bhava, Acharya Devo Bhava, Atithi Devo Bhava. For us today, the first three are very relevant. I would like to just throw a light upon. Now, in this spirit of the definition, whoever gives a knowledge is a guru. And from this standpoint, I would say the first guru in our life is our own mother. And this is not something today's revolution or something. As I said, look at the Vedic culture, Vedic tradition. There, Acharya Devo Bhava doesn't come first. First comes Matri Devo Bhava. And when comes the Guru Vandana, I would say it is nothing but a spirit of a gratitude, acknowledging the contribution of a guru in our life. So basically, we have to acknowledge. And not only we should acknowledge, we must reciprocate. And the first guru in our life, I would say the mother, who have contributed so much in our life. In fact, the whole life, even if you do anything in return to just compensate what the mother might have done in our life, is not sufficient. And by nature, the mother is something the kind, compassionate, nourishing, and therefore, as the doctor said, I think I don't agree with that adjective personally, that he said his mother had been a good mother. I would say mother is always good. I don't think at least a mother in our culture until today, we need the adjective called good mother. We don't. It is insult to the mother. Mother means good. Mother means giving. Mother means caring. That's all. What she knows is only this. And therefore, the first place, imagine in our tradition, in our life, we give to the mother. Matridevo Bhava. Then comes a Pitridevo Bhava. Then comes the Acharya Devo Bhava. Now in this today's context, if this is what really we, the culture we have got, tradition we have got, the spirit we have got, and therefore sometimes when you look into the changes in the society, it's a little painful to see. And the very often it has become the fashion now to send the parents into the old age home. It's becoming kind of a part of our culture, which was never. The old age home concept is not at all part of our culture. Imagine, just look into how they must be feeling. What must be going on emotionally with them? You may choose a best of the Vatican old age home for them. But they are not for best of the things now. Their requirements are entirely different. They don't need your all imported things. They don't need your best of the gadgets. They don't need anything so-called the best. What they need is your care. At least feeling that my children, they care me more than enough. And therefore, the first thing I think what we should do is part of the Guru Vandana. We should see that at least our own parents are never made to feel that. That they don't have to feel that we have to go to the old age home. Just imagine, at least I imagine. And in my understanding, there is no much difference between a old age home and orphanage home. And imagine if any child has to be a part of the orphanage. Definitely, the child has that feeling that I am a deserted. No one is there in this such a vast world for me. No one cares me. I am unwanted. And that is how I am here. The orphanage may be, as I said, very good, wonderful, well-maintained with all the facilities, whatnot. But psychologically, definitely, the child is not going to feel comfortable that where one is placed. Even 20% of the facilities, what is given in the world, this orphanage home, even if 20% of those facilities are there at home, the child has every reason to feel good about it. And just as the child cannot feel comfortable in the orphanage home, I don't think the parents are going to feel that. And therefore, what we must do, or at least we must aim in that way, that see that it is not really something good news that so many orphanages are coming, so many old age homes are coming. In fact, in this country, they must come down. We should have minimums. And therefore, it's an opportunity for us to what we can say, to serve the parents who have given so much. And that much I think we must do that, and it will be a wonderful Guru Vandana. That means first the Matridevo Bhava, Pitridevo Bhava. As I said, it is only acknowledgement, expressing the gratitude what they have given, what they have done. And then the last one, the Acharya, the Guru, who definitely teaches more than the survival, more than the anything else. And we have got a lot more place in the society for such a person. And therefore, what we do is we honor all the three. And the last point or the homework, perhaps the Sharda, she has given, Dr. Sharda, she has given to me to work. And she said nicely that she wanted to be a best of the doctors. Then what I felt is nice. But what we should aim is, not only we should be a best of the doctor, but all of us must aim to be a best of the person. Best of the mother, best of the father, best of the brother, best of, let us say, engineer, best of course, doctor, best of whatever, even a best of the servant. Society need only the best, reliable, including best of the gurus, best of the swamis. All we need, in which area we don't need the best. And therefore, that's nice It was nice opening. I think all of us must take the Sharda's that statement as a wonderful statement, and let us aim that every one of us, whatever we are, we need not be the doctor. All of us need not be the same. But what I am, I want to be the best. And with this, I know all you are hungry. If stomach is making noise, nothing will get into the head, I know. This topic needs a lot of this thing. But with these few words, and doctor doesn't want to say I know about anything about him. And I don't want to say, because every one of us know that he is really such a wonderful person. And one thing, in the spirit of Matri Devo Bhava, if I have to say connected, that my mother in the old days, she was with me. I kept her. And then more than me, who has served her is a doctor. Really. And in her own, that is her Marathi language, she didn't know any other language. She always would tell me that if such a wonderful, the doctor, she would always appreciate in her language because she did no communication. Then she said, if such a nice person was not there, I would have died long before. Years before, I would have died. But lack of language, she could never communicate. But always she had that gratitude feeling, and doctor has stopped really his service to her. As I said, I can say that more than me as a son, he has served. Credit goes to him. And she also lived 95 years, just 2 years before she passed away. And that is what our doctor is. I don't want to say anything. With this, we will conclude. I will say the Purnamadaha. And the last doctor said, doubt, somewhere I think we have the food arrangement. All of us, we will have the Saha Bhojanam. Thank you. Om Purnamadav Purnamidam Purnat Purnamadachyate Purnasya Purnamadaya Purnameva Vashishyate. Om Shanti Shanti Shanti. Hari Om Shri Gurubhyo Namaha. Hari Om. Yes, thank you.
I have only one announcement without mind because they cannot eat the fellows who are outside. First food has Dahi Puri, Pani Puri, Gevar, which is a Marwadi sweet, which is given in Raksha Bandhan, and English type of sandwiches, which Dr. Bhavan sir was very interested in very things like this of cucumber to be in the bread sandwich. So I have made a great effort to my girls. The whole credit goes to all my girls. They learn singing, they have done the cooking all by themselves, and please enjoy the chart and
Function is over. I want to eat and drink. Anybody wants, she'll be sitting here itself, take her the seat. And number two, there are two eating areas. The one on the left side is first one, that is the Dosti room. So please all of you enter that room first. Because the other room is traditional, Harsha, Sri Lanka, rice. So please fill your stomach in the Dosti room. And that will eat out. So please attack it and take the blessings of my life.